CNS infections here. It looks like it's a lot, but it's not. What I want you to remember is that when it has to do with the clinical presentation, it's the same thing pretty much for encephalitis and meningeal irritation. What you want to pay attention to are those specific causes and the predisposing factors. And I will highlight them as we go along. And you will see I will repeat myself a lot. And as a matter of fact, there is nothing, very few things, I shouldn't say there is nothing, very few things you'll be hearing today for the first time. Because this is like, how many more lectures do we have of neurology? Like 2 or 3, right? So by now, you should be like very comfortable with neurology in terms of clinical manifestations. I'm only paying attention to clues. So today I will give you bullet points, what you need to know. So CNS infections are basically infections of the central nervous system. And you know the brain, the central nervous system has brain, spinal cord, right? And it has coverings that we call meninges, right? It turns out that you can have infection of the parenchyma of the brain that we call encephalitis, or you can have the infection of the covering of the brain that we call meningitis. And there is nothing that stops meningitis from spreading into the brain, and there is nothing that stops encephalitis from involving the meninges. So there are situations where you have meningoencephalitis, right? And why is it important? Yes, it is important, because if you find stroke or weakness in somebody with meningitis, that is not typical meningitis, right? That means there is involvement of the underlying cortex, right? If you find somebody with headache and seizure and loss of consciousness and they have neck stiffness, you know, well, there is something wrong with the brain, but why is the covering irritated? Why is the neck stiff? Why is there positive Kernig's and Brzezinski's? You know, those are not clinical signs of encephalitis, right? So there are times you will definitely have both, because the patient will present like that. Then, when the equivalent of encephalitis in the spinal cord is myelitis. Myelitis is infection of the spinal cord tissue, okay? And then you have subdural empyema, or what's called a brain abscess. And then you have this condition here, acute disseminated encephalomyelitis. It's exactly what it is when you have infection of both the brain and the spinal cord, right? Disseminated, widespread inflammation of the brain and spinal cord. So these are just basic terminologies, and I can always tell you, you must learn to pronounce these words. When you make mistake in pronouncing words as a clinician, you paint yourself in a very bad light. It's like trying to speak a language when you don't even understand the alphabets. It does not matter what you know. If you cannot communicate it, you don't know it. You know, so I need you to pay attention to those words and pronounce them correctly. Now, let's start with okay, meningitis. So I have this gruesome picture of the meninges, right? And this side looks when it's inflamed, right? You remember in anatomy, right? When you dissected, you saw the brain, right? You saw the meninges. Was it this red? No. This is what it looks like when you have meningitis, when you have irritation. Okay? Now, meningitis is usually viral, but it can be bacterial or fungal. The good news is that the viral meningitis is more common and it's less severe. So patients often recover from it in about a couple of weeks. Okay? And you don't really have to do anything but support the patient to recover. Bacterial meningitis is less common, but it's more deadly. If brain abscess is going to follow meningitis, it's going to follow bacterial meningitis, not viral meningitis. Okay? And then you have this fungal meningitis that are even much less common, but they are more likely, they are more common in immune compromised patients, patients with direct neurosurgical interventions and devices. So, if you see somebody with meningitis who's receiving chemotherapy for cancer, if they give you signs of meningitis in somebody who is on immunosuppressed therapy following renal transplant, if you see meningitis in somebody with AIDS, you are not going to be thinking viral. That person is more likely to have a fungal meningitis than a viral meningitis because of these risk factors. That is the way I want you to interpret this. So if somebody carries a VP shunt, a ventricular peritoneal shunt, and they've had this shunt for a long time and they're switching practice and you're not becoming the primary care doctor, and the patient tells you, I've been having this headache and my neck is stiff. You're not going to say, oh, don't worry, it's a viral meningitis, that's the commonest cause. No, you know he carries a VP shunt. He's more likely to have a fungal meningitis. And fungal meningitis don't go away. You have to treat fungus every single time. You understand that? Okay. So that is how I want you to see these causes that I listed here. So let's start with viral meningitis. Viral meningitis, you know, millions of viruses, right? But thank God, they all don't have the capabilities to cause meningitis the same way. So meningitis is most commonly caused by enteroviruses. So your Coxsackie virus, your echovirus, and other non-polio enteroviruses. So enteroviruses are the most common cause of viral meningitis. Next to them are herpes simplex virus. And you know there are two types of herpes simplex virus, right? Type 1 and type 2. Remember that, right? Now, there is a special type of meningitis caused by herpes simplex virus type 2. It's called molarate meningitis. Molarate is named after the guy that named it. And the reason it's special is because, you know the way you get zoster, right? Recurrent. Whenever somebody has the herpes virus incubating, you immune suppress them, you give them steroids, you get them worried, you get them stressed, they get a breakout. That same thing happens with herpes simplex virus type 2. So they get primary infection, and the bug stays in the ciliary ganglion, and from those ciliary ganglion, it can backspread, reactivate and backspread to the face and the brain, and it happens repeatedly. Okay, so that recurrent meningitis, of course, it's a viral meningitis, so it tends to be lymphocytic meningitis. You'll understand what that means in a little bit, right? That is what makes it merit that name, molarate, because it tends to be recurrent, just like zoster is, right? And if you look at my note here, telling you that both herpes virus and varicella zoster virus can spread from the cervical dorsal root ganglion backwards to the meninges and forward to the skin, right? And I just need you to also know that meningitis tend to be very common around this time, right? And again, it's driven mostly by the seasonal variations of enterovirus infection. Enteroviral infections tend to be very common in the summer months, so meningitis tend to be more common in the summer, okay? And of course, when the meninges are inflamed, the CSF gets contaminated. And depending on what is causing the inflammation in the meninges, the type of contamination you get in the CSF differs. So when you have viral meningitis, You get increased white count in the CSF. Normal CSF has about 0 to 5 WBCs, mostly lymphocytes. When you have viral meningitis, you could have as high as 500 cells per mil, right? And it's predominantly a lymphocyte because it's viral. Okay. Generally speaking, when you have bacterial infection in the body, it's the polymorphs that respond. When you have viral infection or cancer, it's the lymphocytes that respond. All right? And then proteins tend to be normal. Glucose will be normal. And opening pressure, well, they're usually normal, right? The reason glucose is normal is because viruses don't eat glucose. Bacteria do, right? And the reason protein is normal is because there isn't a lot of vigorous inflammation. Okay? So that is the nature of CSF when you have viral meningitis. You have normal opening pressure, white count, generally under 500. Protein is normal, glucose is normal. Many times what they will give you, they give you CSF findings and tell you what is the cause of the meningitis. It's very basic stuff. Okay? So that you must know that very well. In fact, one thing you must know, like the back of your hand, and I will expect you to carry a flashcard for, is analysis of any body cavity fluid. Joint perfusion, what does it look like in bacterial versus rheumatoid arthritis, all those things. Pleural effusion, what does it look like in transudate versus exudate? Ascites, what does it look like in high gradient versus low gradient? What are the differential diagnoses? What are the historical features of those differential diagnoses? You understand what I'm saying? Okay.
Dr. Martin,
Yes.
is the molarate, is it specific to HSV?
Yes.
So not,
Yes. That's why I
not
put.
varicella?
No. Molarate meningitis, HSV2. My note here is, I know you're familiar with zoster. So I'm using zoster here to help you pin down molarate. Okay? Bacterial meningitis. About 60 to 70% of bacterial meningitis is caused by Streptococcus pneumonia, right? And about 18% group B Streptococcus, and another 14% Neisseria meningitidis, about 3% Listeria, and then about 7% Haemophilus influenzae. Now, those numbers is what you find generally speaking. But there are specific criteria that will make you think of this more than the other. So look at, for instance, Neisseria meningitidis. Neisseria meningitidis is more common than strep pneumonia in children 2 to 18 years old. And close quarter living is a major risk factor. So if you see a 16-year-old high school senior from boarding school, call parents, say your child is sick, and parents brought the child to you, say just got sick from school, I went to bring him home. And you were there in the emergency room, wherever you are, and the kid is having headaches, fever, neck stiffness, you know this is meningitis. You would not think about strep pneumonia. Because the kid is from boarding school, right? And it's between 2 and 18. That kid is more likely to be having Neisseria meningitidis. Why is this bacteriology important? Because you're going to do a lumbar tap, and you're going to send it to the lab. Immediately from the tap, you can look. You can see it's cloudy, but that's about it. You can see it came out under pressure, but that's about it. You will not know which bacteria is there, but you need to treat that kid now before the culture result comes back. So that is why it's extremely important to know the bacteriology of these life and death illnesses, right? So in that case, you will start your antibiotic therapy with Neisseria meningitidis in mind, okay? Now, on the other hand, listeria in the general population accounts for less than 5%, actually 3% of meningitis. But if your patient is immune compromised, elderly, pregnant, or alcoholic, he is more likely to get listeria, right? And in the first 3 months of life, like you've done pediatrics, right? Okay. Did Lorenza tell you meningitis and group B, Haemophilus, and listeria as the leading causes of meningitis? Okay, so you remember that when you are dealing with infants in the first 3 months of life, the leading causes of meningitis are this, right here. Haemophilus, what the heck is moment? Okay. Haemophilus influenza, type B, listeria, right? And group B. Okay, so strep pneumonia is not common in infants. Okay, it's less, we are more likely to be dealing with Haemophilus, listeria. And all of this is because, remember, in the first 3 months of life, the child has the passive immunity from the immunoglobulin from the mother, right? It is after 6 months that child now develops his own immune system. So in between those 3 and 6 months, the child is really vulnerable because he's losing his mother's immunity and developing his or her own. And she has not really been directly challenged by these bugs, because for her to develop her own immunity, she has to be challenged by those bugs and then recognize them and then respond to them appropriately. So that is the reason you notice that the listeria is common, just like immune compromise also in children as well. Okay? Okay. And you remember that Haemophilus is encapsulated, right? They are more difficult to deal with. Encapsulated bacteria are more difficult to deal with by the body's immune system. So the young child's immune system has difficulty with encapsulated bacteria, especially Haemophilus. Okay? So the reason I'm telling you this is so you have a way to remember which is common where. Okay? So Haemophilus group B streptococcus, like in everybody, but in addition to that, listeria and Haemophilus influenza in infants. Okay? And what do you see? Of course, if it is bacterial, CSF will show increased cell count in CSF is called pleocytosis. So when the increased white cells in the CSF is polymorphonuclear cells, we say the CSF exhibits polymorphonuclear pleocytosis. Okay? So if somebody asks you what are the features, CSF features in bacterial meningitis, you remember increased protein, low sugar, and then polymorphonuclear pleocytosis. Okay? And the CSF will come out under increased pressure. Okay? Are we good? Excellent. So fungal meningitis. See, look at the risk factors, right? All you need, it looks like a big deal table, and it's big, but nothing. This is one of those things I tell you. Look at the table very well. It's only telling you two things. Fungal meningitis can be caused by fungus. Cryptococcus, very important. You see it in immune compromised people. You're going to need Indian ink for crypto, and you have to do culture and CSF for everything else. So your exam, your questions, your clinical challenge does not come from anything complicated, but recognizing your risk factors. Who are you talking with? You see, in practice we say it is more important to recognize what who has what than what has who. It's more important for you to recognize who is your patient that has the disease, not the disease in the patient. Because that patient will determine what kind of disease they have. But if you totally focus on, oh, it's just another meningitis. No! It's not, there is nothing like another meningitis. Take a good look. People may have the same diagnosis, but have totally different diseases in terms of pathophysiology and the underlying basis for it. Okay? So this big table here just tells you Cryptococcus neoformans, you have to think about it in immune suppressed, especially not HIV, AIDS, okay? AIDS and cancer patient. And it tells you how is it transmitted. It's respiratory, sometimes secondary methylogenial spread. What is the symptom? Fever, headache, altered mental status, focal neurologic deficits, and seizures. Now let me ask you something. Is focal neurologic deficit a common feature of meningitis? Thank you. Is seizure a common feature of meningitis? No. So the only time you get these seizures and focal neurologic deficit is when there is fungal meningitis or when there is associated encephalitis. Okay? And the only other time meningitis gives you nerve deficit is when it's at the base of the brain, what is called basal meningitis. Can anybody tell me why you will expect cranial nerve deficits in basal meningitis? Thank you. The cranial nerve are exiting, and as they're exiting, they are being covered with the meninges. If the meninges is irritated, the nerve is going to be trapped in that inflammation. So they will have. So whenever you see neck stiffness, headache, positive Koenigs and Brzezinski, and you have any cranial nerve deficit, you must think about 4 types of meningitis: fungal, basal meningitis. As a matter of fact, we generally just say fungal or basal meningitis, or we call it meningeal carcinomatosis. When you have metastasis from breast, what else goes to the brain? Lung, yeah. That at the base of the brain, irritating the meninges and trapping the cranial nerves at the same time. So this is not unique to fungal meningitis. It's very common in carcinomatosis and also in basal meningitis. And you notice that of all fungal meningitis, you need to culture the CSF, and that takes weeks, at least 6 weeks. Your patient is dead if you are waiting for culture to treat your patient. There's only one exception I want you to remember. Anytime you hear Cryptococcus, remember Indian ink. Okay, it's the only fungus that we use Indian ink to diagnose. That's the kind of a thing I will put in a flashcard. Because this is, look, if you wait to review my note later, the last thing you will pick up in your review is Indian ink. You need to carry that one on a flashcard. Indian ink, Cryptococcus neoformans. Just know, because it's not, well, it's just something you need to know, and you may not pay attention to when you're in a hurry to review. Okay, you need to carry that in a flashcard. I'll be sorry to be telling you, bless you, to be telling you what I think you need to carry in a flashcard. So that because there are some things you really do need to carry in a flashcard, and you will not remember them if you don't do that. Okay? And then it tells you how they are spread. There is nothing special about how any of them is spread. It's either in hematogenial, respiratory, secondary, and that is not important. Doesn't matter how you got it. That does not have any therapeutic implication. You're going to treat them for what they have anyway. Okay? So, generally speaking, how does meningitis present? Headaches, altered mental status, if there is involvement of the underlying brain tissue, right? You can have photophobia, you can have phonophobia, neck stiffness, high fever, depends on what is causing it. If it's fungal meningitis, will you get high fever? If it's viral meningitis, will you get high fever? No, okay. So this is just common, non-specific manifestations, and then you get this particular rash only if it is meningococcal, right? Right? Okay. But see what I was just telling you. TB, another cause for basal meningitis. Mycobacterium tuberculosis causes a basilar meningitis that results in 3 complications: hydrocephalus, vasculitis, and stroke. Even though I said TB, TB is not the only one. Fungal meningitis will do that as well. Okay? Carcinomatosis will do that as well. Okay? And for the reason that I just told you, because at the base of the brain, you have a lot of blood vessels that could get involved in that inflammation, right? That is why you have the vasculitis. And of course, if you inflame the blood vessels, you occlude the blood vessels, you cause an arterial or venous occlusion. You can cause a stroke, right? So it is very easy. And then, of course, you obstruct the ventricular foramina, you cause hydrocephalus. So you see, these hydrocephalus, vasculitis, and stroke, they are not necessarily unique to tuberculosis, but basilar or basal meningitis. And the way you know it is when you do a CT scan of the head, like you would always do in anybody. If you think somebody has meningitis and you examine them and they have 6-nerve palsy, you know that it's not meningitis. That's very straightforward meningitis. You do a CT scan. Invariably, if it is basal meningitis, you will see this base of the brain will light up. Basal meningitis is basically meningeal irritation that is predominantly around the base of the brain. Okay, they call it basal or basilar. Okay? I want you to remember that. Okay? What else about this one? Okay, signs of meningitis, you know everything about Koenigs and Brzezinski. I'm not, right? I can make that assumption, right? I've talked about this so many times now. All right, so lumbar puncture. Again, this is not a class for lumbar puncture. You're supposed to do this in your lab diagnostic, but I just want you to know, I know that this is probably what they told you, and this works. There are 2 ways you can do lumbar puncture. You can have the patient. There are 2 ways you are often taught to do lumbar puncture. Patient lie on the side like this, or they sit on the bed and lean on the table, right? Those are the 2 standard techniques. None of them is good. You find out with practice that you have to find what works for you. What works for me and works for most of my students is when you have a patient like this, put a pillow in between the legs. And I'll tell you why it works. See, when you have the patient on a soft bed, right, and they lie like this, it is impossible for you to keep them straight because the platform is not solid, right? So they will be tilted. And once they tilt, that sacral iliac crest line that points to L3, L4 is out of alignment. You put your needle in that space, you're going to hit a bone. And most of the time, if you put a pillow in between the leg, you help stabilize the pelvis. So even if the floor is not even because of the cushion, you take the pillow in between the legs, keep the legs apart, and stabilizes the pelvis for you. And then that sacral iliac crest line that you use to identify L3, L4. Once you identify the spine and you go right underneath the spine, you will go straight to the canal. If you don't do that, you will hit the bone and you will keep messing around in there. You will ultimately get to the canal, and then the whole thing will be bloody. You will never be able to tell subarachnoid hemorrhage from meningitis. Okay? Now, why is it that it doesn't work when you have the patient do this? Because Every normal human being, once you stick in your needle and you hit the bone, they go like that. Once they go like that, your needle point is already out of your focus area. You have to now keep going like this again for the same reason, okay? So, and moreover, when you do like this, the way your spinal, the point of having the patient flexed is to open up, right there. The reason you want the patient to flex is to make sure that I don't want to break anything. But by flexing it, you want these spines to open up. So you can go.
Yeah, take them. No, just pick up the whole silver thing. The thing that's in there, and just take it. But this is
So, what I'm trying to say to you is that the reason having this patient sit and leaning forward on a table doesn't work is because in order for you to go into this space, this is where you want to go, right? You want to go here. You need these spines out of the way. In order for you to go here, you need a maneuver that spreads the spine out. That's why you flex. You don't get much flexion by just having somebody curve their back like this. Not a whole lot of flexion. You get the most flexion when they're like this, because you're gonna get help to really flex the spine, right? And the only challenge you're gonna have in this position is the stabilization of the pelvic girdle. And that's why you need the pillow in between the legs. And then that really does help, okay? Remind me to put this back, okay? Before somebody gets us in trouble. Thank you. So you see, positioning is important. Identifying a landmark, you know that the imaginary line through the lumbar crest goes to the L3, L4 space. You were taught that, right? Mm-hmm. Okay. And then you mark up the site. You know how to do it, right? You clean. Okay, well, tell me how do you prepare your site? How did they tell you to prepare your site? 3 important steps.
The 3 swans, you do one. And then
Okay, what do you use first? Betadine, then what? Then what? Okay. There are three important steps. You must degrease the area. And when you degrease, betadine sometimes is soapy, so it's together. So you degrease and you desensitize at the same time. You disinfect at the same time, right? You degrease, you disinfect. The alcohol is to help you dry. So the steps is degrease, disinfect, and dry. And you always start from the center and you go outward and you never go back in because you will contaminate the site. All right? Now, before you start doing all that, you use the bottom of the swab to make an indentation. After you've identified your spot, you push it in really deep, right? Then you start cleaning so you can see that space. That is very important because if you know why you're doing what you're doing, then you always do it correctly. You will not say, well, if you don't have it, that's fine, give me alcohol. That means you have no idea what the betadine was doing, because what the betadine was doing is different from what the alcohol is doing. If you don't know why you're doing what you're doing, then you come to some place, they'll say, oh, we don't have alcohol here, but we have betadine. Then you know you have to kind of wait for the betadine to dry. Okay, because the purpose of the alcohol is to help you with the drying, but this is not the class. I just want to make sure I tell you anyway. And then when you're numbing the skin, the first thing you're supposed to do is to use a hypodermic needle, you know, the one with the blue hub, right? And you do it like you're trying to do a PPD. Put it right under the skin. You see the well. If you do it correctly, the surface will be white, even in the black skin. If you raise the well properly, the surface will be white. Once that is done, you now get your anesthetic needle itself. You put it in that center of that wheel that you raised. You push, the patient shouldn't feel any pain. Then as you go deeper, you aspirate to make sure you're not in a blood vessel. Then you infiltrate. When you infiltrate, you advance. You pull to make sure you're not in a blood vessel. You infiltrate, you push. You aspirate, make sure you're in a blood vessel, infiltrate, push. If you do it like that, lumbar puncture and bone marrow biopsies are painless. I used to do tons of this stuff across the street. If you know how to numb the skin, it doesn't have to. Of course, your patient will have pain at the end of the day when your anesthetic is out, but the procedure itself should be pain-free. So that is what the reason I like this, because it really set it up for you properly. You know, mark the lamp site, cutaneous anesthesia, then deep anesthesia, right? Then you now do your lumbar puncture. Of course, because before all that, you have great and gotten your patient ready. You collect the CSF, and people measure opening pressures. But the whole process of measuring opening pressure is so cumbersome, and it really gives you very little information. If it's not viral, pressures will be high. What do I care? Whether it's little high or a lot high, you know. But you're supposed to measure opening pressure. Okay, so this is a table that tells you what normal CSF looks like. And like I said, see the pressure, 90 to 180 millimeters. And then protein and glucose. What I want you to remember is that normal CSF is like water. When you have bacterial, it becomes cloudy. Call that turbid. When it's viral, it will still be clear, right? When it's tuberculosis, meningitis, is so turbid that it becomes opaque. You can't see through it. And when you even look, you begin to find protein threads inside it when it's TB. Fungal looks so much like viral, right? Pressure is increased anytime there is increased inflammation, except that in viral meningitis, pressure could be normal. But generally speaking, that's why I don't put too much emphasis on opening pressure, because it's increasing. It's non-specifically increased in all meningitis. It doesn't tell you much, you know, other than for you to know that it could indeed be normal in viral meningitis. Okay? And if you look on here, chloride is not something we often measure, right? But if you're really suspecting that somebody has an unusual meningitis like fungal or TB, then chloride becomes very helpful. Okay? Okay. And basically, chloride is normal in viral meningitis. And you see, this table, it says chloride is low in bacterial and TB and fungal. In a more practical sense, we use chloride when we're thinking seriously about TB. Okay, so it is not the chloride information by itself, but if you have gram stain, if your gram stain is negative, right, and you have low chloride, that is an indication that this could be TB. You understand what I'm saying? Because you know, you don't see TB in gram stain. You have to do acid fast. Right? So if you, and gram stain is a lot easier. Many of us can do gram stain. So if gram stain is negative and chloride is decreased, almost always, that is TB. You understand what I'm saying, right? Okay. And then look at the white count in bacterial meningitis. It's usually in the thousands, right? Whereas in fungal, it's not as high, but let me break this down for you. This big old table here, don't waste your time trying to memorize anything. Just remember that when it is viral meningitis, opening pressure should be high but maybe normal, right? Generally speaking, the cells are under 500. Protein is normal. Glucose is normal. Chloride, if measured, is normal. Bacterial meningitis, cells, of course, there will be opening pressure, almost always. Opening pressure is never normal in bacterial meningitis, right? Cells are in the thousands. Protein is increased, glucose is down, right? And chloride may be decreased. It's exactly the same thing for TB and fungal, except that the cell number and type might be a little bit different. Okay, so that is all that is on that table there. You know, I need you to learn how to synthesize information into less words so that you can carry it with you. Okay, and today they have all these pocket guides that you can flip out, but you won't be allowed to take it to your exam. So you have to commit some things to memory. All right, so when can you not do lumbar puncture in somebody you think may have meningitis? If there is evidence of intracranial hypertension. Why would you not want to do lumbar puncture if there is evidence of intracranial hypertension? Herniation. What will happen to the patient if they herniate? They will die right there. From the time your needle goes in, and let me ask you, what is the clinical sign that you would depend on for intracranial hypertension that will alert you that I shouldn't do a lumbar puncture in this person? Papilledema. How many of you believe papilledema is a reliable sign for intracranial hypertension? It's not. Don't make that mistake. Yeah. And that is often tested. It is not that it is not reliable. Whenever you see papilledema, the patient has intracranial hypertension. So it's very specific, but it's not sensitive. And the reason it's not sensitive is because it takes 24 to 48 hours for papilledema to develop. Because remember what papilledema is, right? It's increased pressure, venous, retinal vein occlusion, then fluid exudation, and then come up in the optic disc. That doesn't happen immediately. That takes a long time. So just because somebody does not have papilledema does not mean they don't have intracranial hypertension. If you depend on that, you will kill more people than you save. Okay. So remember, I want you to remember where papilledema fits in the scheme of things. Yes, it's specific for intracranial hypertension, but it's not sensitive. Okay. Its absence does not mean there is no intracranial hypertension. Okay. Cerebral herniation, impending herniation, possible in focal neurodeficits, all of that level of, in fact, the most common manifestation of intracranial hypertension is altered level of consciousness or focal neurodeficit. That is what tells you that this patient may have increased intracranial hypertension. Okay. Coagulopathy, of course, you don't want to do that. If somebody has liver cirrhosis and they have coagulopathy, because you're going to puncture vessels and they won't clot. If somebody has had prior lumbar surgery, like now that we do all this spinal fusion and they put spines, titanium implants, all this stuff that these orthopedic guys are putting into people. You see, you want to do lumbar puncture, you see a scar in the back off, because you don't know what you're going to be dealing with. Okay? So generally speaking, it's not that is actually a relative contraindication. It just means that you cannot do a routine lumbar puncture. You cannot assume anything is normal once you see that. Surgeons have been there, humans have been there. Nothing stays the same after it's been touched by humans. Okay? So if they have had surgery, you can't assume that everything is the way it was. You can't. Okay? Again, severe vertebral osteoarthritis and degenerative disc disease is a relative contraindication because you can actually do a CT scan and see how bad it is and decide how you're going to go, right? So of course, significant cardiorespiratory compromise. You do would you do lumbar puncture on somebody that is in shock? I mean, shock will kill your patient before meningitis does, right? So you stabilize the patient. You don't do lumbar puncture in critically ill people. Okay? Or say you want to do a lumbar puncture, the next thing you see a big abscess right there in line of your iliac line. Would you stick a little abscess to do lumbar puncture? You will precipitate it even if there wasn't lumbar puncture meningitis there before. So you back away from that, right? Okay. And these are common sense complications, right? Okay. Of course, space occupying lesion. If you know somebody has a history of brain tumor, even if they have had surgery, and now they're presenting with headache, neck stiffness, and you think they have meningitis, just because you know they have had brain tumor, you must do a CT scan first to make sure that this is not a recurrent mass. Because what will happen if you stick a needle in their back, if they have brain tumor, again they will herniate. They will herniate, yes. It's called coning. Right? Yeah. It's a kind of herniation. Coning is herniation through the foramen magnum. That the one that compresses the brainstem and causes cardiorespiratory arrest. Okay. Uncal herniation is the one that gives you the blood problem. Okay. Okay. Like Wizard of Oz. Okay. So why is it important, like I said, to identify which bug you might be dealing with? Because generally speaking, if you go to emergency room, when you're doing emergency room rotation, you look at everybody with meningitis, the ER guy does not even think. Once it's neck stiffness, fever, self-reaction. Okay, self-reaction, 2 gram IV, boom. Occasionally cefotaxime, but self-reaction is what most people use, right? But if you think your patient is at risk for listeria, you have to add ampicillin, right? And if you're thinking that this could indeed be strep pneumonia, you have to have vancomycin. Okay. So you see, that is why it's important to have a thorough understanding of the bacteriology of meningitis. We didn't do this when I was in training, but there is some evidence now that, in fact, that when you give dexamethasone to patients with meningitis, you would have thought that they would say it reduces the incidence of inflammation or the degree of edema. No. In children, it reduces inflammation and the risk of sensorineural deafness. Okay. Why do you think that is? What type of meningitis will cause deafness? Is it basal, non-basal? Basal, exactly. Why do you think this deafness in children that should happen only with the involvement of the basal base of the brain is common in children? Huh? Yeah, they have small heads, right? So very quickly, one part of the meninges gets inflamed. All of the meninges is involved already, right? And to minimize the sensorineural deafness as a complication of that meningitis, if you give them dexamethasone, you can reduce the deafness as a complication. Okay? Very important that you remember that. What?
There's a lot.
A lot of nothing. A lot of nothing. It's a lot of nothing. We're talking about complications of meningitis. There are only 3 of them. Okay? Number 1, inflammation of the meninges releases inflammatory cytokines and other mediators. And that increases the blood-brain permeability and gives you fluid extravasation that can give you seizures and subfusions. Pay attention to the purple ones. You see, this is, I could give you another slide that just lists complication. The reason I'm giving you this one because not only does it give you the complications, give you the pathophysiologic basis for it. So it's not all the complications. All the complications are in this, what is the color? Pink, right? Okay. The pink is really the complication. The purple is the pathophysiology. Okay, so let's take it one by one. So you get meningitis, you get inflammation of the meninges, you all know that. Release of inflammatory cytokines and other mediators, okay? What would they do? They irritate adjacent cerebral cortex, causing aposynchronous neural activity. So they irritate the underlying brain tissue. That's why you get the seizures. And so seizure is a complication of meningitis. And it has to do with direct irritation of the cortex by the cytokines of the meningeal irritation, right? It increases the same cytokines, the inflammatory cytokines, they increase the permeability of the blood-brain barrier. And that is the pathophysiology for subdural effusion and cerebral edema in meningitis. Okay? They irritate the arachnoids, granulations, and they block CSF reabsorption. Where is your CSF reabsorbed? At the arachnoid granulation, right? So when you irritate and you block that, you get non-obstructive communicating endocephalus. And how would your patient present? Obtundation. So somebody with meningitis can be completely obtunded, like out, like light. Okay, so don't be intimidated by any. I'm hoping that by the time you finish with your didactic here, you will learn how to read charts like this. Because you know, I comb through the web to look for the figures that say it like I want it said. And sometimes that takes a long time. And when you react the way you do, I feel like, should I be giving you the simpler ones? But this is the summer of your didactic year. I can't be chewing meat and giving it to you. You have teeth now. Right? You should be able to chew on it yourself and crack the bone too. Right? So that when you become instructors, you will be able to look through and look for the most sophisticated slide that tells the story you want to tell. Okay. So, and if you look at it, here you get seizure. That is the end. Seizure is the end. It doesn't lead anywhere else. But see, as a result of the inflammation of the meninges, directly the cranial nerves exiting the CNS through the inflamed meninges can be irritated themselves. I told you that already, right? And what do you get? Cranial nerve pulses. And now it tells you which nerves are vulnerable. 3, 4, 6, and 7. Right? And you see that that is a direct consequence of the inflammation of the meninges. Right? I mean, this slide is, it's like, they say pictures with 1,000 words. This one is 1,000,000 words. Right? Now let's take a look. You get subdural effusions and cerebral edema. Edema in the superior aspect of the brain pushes down the brain, squeezes the uncle. We just talked about herniation, right? And what do you get as a result of that? Transcensory herniation gives you the uncle herniation that gives you the bone, right? So you notice that everything here, seizure, cranial nerve pulses, herniation, obtundation, hydrocephalus, subdural effusion, they are all direct consequence of inflammation of the meninges. Then let's go over here. Infection of the cerebral arteries by bacteria causing the meningitis gives you vasculitis, right? Vasculitis of intracerebral artery, damage the endothelium, prone to thrombosis, you get ischemic stroke, right? The inflammation can damage the vessel from outside. and cause the vessel to rupture, give you hemorrhagic stroke. Right? So it is, which one would you prefer? For me to list stroke, period, as a complication of meningitis, or to give you that meningitis can actually cause ischemic stroke and it can cause hemorrhagic stroke by different mechanisms, although involving the blood vessels. You see, so, and then that. And then finally, bacteria can enter the general circulation and cause sepsis, and see what happens. DIC, organ failure. And remember Waterhouse-Friderichsen syndrome? Right? Yeah, exactly. When you have the hemorrhage into the adrenal as a result of meningococcemia. Right? You remember that? We just talked about it last week. I'm sure you didn't remember it. But just pretend like you did. Okay? Alright, so I don't know who did, somebody did it. See this here, somebody. I just like, this is what I want to talk about, but I saw this one and I had this space, so I put it there. I think it's useful. Meningococcal disease most often affects teenagers and early adults. Okay? I already told you all of this. What I want to talk about is how do we prevent this meningococcemia? You have, if you're going to go into the military, boarding school, you have to get meningococcal vaccination, measles, mumps, and rubella, and hip vaccinations. This is the reason for all this. And generally speaking, kids that go into these close quarter livings also get screened for group B streptococcus because there are people that carry it in their nasopharynx. Okay, so you get squab, and you can actually be treated to eradicate it before you go. And most importantly, believe it or not, precaution, cover cough, hand washing, and being very careful with sharing personal items, especially these kids that play sports. They share water. Yeah. And some people know how to drink from bottles, some don't. There's some people backwash into the bottles. So that is really all about meningitis. That's 1 hour. It's pretty straightforward, right? So now you know that if I was to give you a picture of headache, neck stiffness, positive Koenigs and Brunzinski, and I didn't give you a fever, that is not likely to be meningitis. That's more likely to be subarachnoid hemorrhage, right? If I tell you somebody presents with headache and vomiting for 3 weeks, but in the last 3 days, they now have weakness and they have neck stiffness, positive Koenig and Brzezinski. I said the most appropriate next step is lumbar puncture, head CT. Do head CT. You not do lumbar puncture in somebody with focal deficit who looks like they have meningitis. You kill that person. You understand what I'm saying? So these are these questions will be pitched. What they're testing is, do you understand the ramification, the varied causes of meningitis, and do you know how to use that information when you are encountering a patient? Do you know when to stick a needle and when not to stick a needle? You know, this is the way they will ask, but nobody will ask you, I don't think, especially these days, they are rewarding the way they test you guys, and I think it's a good idea. Your exam is now being more clinical. Nobody will tell you contraindications to lumbar puncture. Which of these? Abscess, brain tumor, that's nothing. No, the ideal thing is to present you a patient with that complication, because that's what you're likely to see. Patients don't come to you and say, I have meningitis and I have brain tumor. Want to do helping? That's not how they come. They just tell their own story. You have to use your skin to filter the information and use your training to decide what to do for them or with them. Right? Good. Any questions? Good, okay, good. Encephalitis, this is easy one. So encephalitis is basically inflammation of the cerebral parenchyma. Mostly viral, really. Bacterial is kind of rare, but it's still possible. You have fungus, you have protozoan, you have the prion disease, and you have the autoimmune, right? the ones I want to pay attention to the most is the viral, because they are the ones that you're likely to see. Most encephalitis are viral, okay? Now, when they're viral, they could come from human to human, and the commonest one in that case is HSV1, okay? Is the commonest one. When they are not from human to human, they are zoonotic. Zoonotic infections are viral infections or infections in humans where the viral reservoir is not human. Right? So the viral reservoir could be a primate, could be a rat, could be anything, other animal, and then there will be some kind of transmission between that animal reservoir and the human, like the HIV, you know, the green monkey bullshit story. That came up, right? You all know where HIV came from, right?
But it was a mutation.
Oh yeah, that's the bullshit story. Right?
Which one?
You say it was a mutation of the virus.
Yeah, mutation, that green monkey nonsense they came up with. HIV was actually, I've been warned not to share the article anymore, but I actually have the documentation that proved that HIV was manufactured in Foster District, which is a military lab, right? It was supposed to be a germ warfare, right? That went sour. And you know where they tested it? It was tested in Uganda. It was given to them like 3 vaccines. You know? So where they came up with that cock and bull green monkey story, that is for the uninformed. But you can't share this. I would be naive. Right? Yeah, actually, I have to, because it was my ID. Oh, you know Dr. Dewan, right?
Yeah.
He was a fellow under Dr. Dewan when HIV first came out. That actually shared that article with me. Okay. See no evil, hear no evil. All right, so when it comes from other animals, it could come from birds. So birds are the reservoir, mosquitoes are the vectors, right? An example of those is West Nile encephalitis, Eastern equine encephalitis, Western equine encephalitis, St. Louis encephalitis, Japanese encephalitis. Well, you can imagine that if it says equine, right, it's more likely from horse, right? Okay, and the Japanese one is from pigs, right? It could be from rodents, like in lacrosis and encephalitis. It does not matter whether it's St. Louis or Japanese. Encephalitis is encephalitis, okay? Why then am I telling you all this? Because I don't know. Somebody can tell you a story because somebody went to Japan and then come and present you with clinical manifestations of encephalitis. And they may want you to actually know that there is something called Japanese encephalitis. Okay? Direct rabies, bats and skunks and dogs worldwide. And rabies is what you're likely to see as a cause of encephalitis in the US because, I don't know, for some reason, Americans are the only ones I know that see danger and go towards it for the thrill of it. You know, I mean, if you look in all over the world, I mean, look at those people that died trying to climb Everest the other day. How many deaths? You remember? And people are still lying up. They say people are dying there, and people are lying up to go there. I'm like, these are very interesting people. And look, there is something about the American spirit. It's indomitable, and it's a very resilient spirit. If you understand that spirit, it is the best human spirit there can be. Very resilient. You know, Americans are the only ones that will go to a place where there is Ebola because they want to go save somebody, even if it means them dying. And the reason they could do that is because somehow they have come to be at peace with death. Most Americans are not afraid to die. They would rather die for something than live for nothing. It's a very unique, that is what makes our current president un-American. He has no idea what the founding fathers had in mind when this great country was put together. Americans said, you know what the Russians call America? An experiment. Because when this country was put together, everybody in the world didn't think it was possible. And you have strangers all over the place come together and build a country that will be for everybody and everybody will be at peace. You're trying to create world peace by creating a country. That is the concept. And they've done remarkably well. I mean, how many people came together building this country? Some came by force, some came by choice. But at the end of the day, the country was built with so many brains together. You know what I mean? And I just even get here. Yeah, bats and skunks, right? Because there are still people that are raving, they go into caves just trying to figure out what cavemen live like. Like, what do you care? We have cars now, we have guns. What does it matter how they live? But there are those that will get out of their country, get on the plane, to go look at caves and bats, and sometimes they get busy. And then they get busy, and then they come back with rabies. Right? So just remember viral encephalitis, right? And then bacterial is usually 3. Lyme disease, syphilis, and TB. And you know Lyme, right?
Yeah.
It's somebody has been in the woods somewhere, right? So usually that story will be given to you. It will be like a kid came back from camp, and mother brought the kid to you now with signs of encephalitis. And the key word is that he's been camping,
Yeah.
right? Tuberculosis is usually an immigrant. Most of the time from South and Central America or from West Africa, right? Fungal, you have to think about crypto, immune compromised. Okay? You know mucormycosis? Did the ID guy talk about mucormycosis to you guys?
Yes.
Okay. Then protozoan, toxo, and malaria, right? Malaria is a big one. Okay. Then prion disease, you all know about that, the mad cow disease. And then I want you to remember this one, autoimmune. Autoimmune. It's called Rasmussen encephalitis. It's autoimmune. That is the one that you will see in a kid that has an autoimmune disease. It could be rheumatoid arthritis, it could be juvenile rheumatoid arthritis, it could be something that's usually some background autoimmune disease. Okay? So you see, these causes here, they are not random. It's because they will give you a picture. I will give you a picture. So you need to remember them. This is another one that I think you need to carry a flashcard, Rasmussen, because it's weird and you're not likely to remember it. Carry it on a flashcard. Okay, write it. This is the picture of what I was trying to tell you about herpes, encephalitis, how the virus, after the initial infection, sits right there in the ganglion, and when the patient's immune is suppressed, it gets reactivated and spread backwards, right? And can give you encephalitis. Okay, 99% of the time, this encephalitis is by HSV1. HSV1, okay? We talked about this earlier, but it was for meningitis, remember? Like about malaria, right? Okay, so this is the same pathophysiology for malaria. Okay, now how does encephalitis present? See, look at all this stuff right here. Is there anything specific? There's nothing. Everything here emotional problem, memory problem, physical difficulties, personality changes, inappropriate behavior, epilepsy, inability to understand, communicate, problems with new learning, cognitive problems. What the heck? Nothing here. This is basically delirium. Right? All these are areas of manifestations of cortical dysfunction, depending on which part of the cortex. Are you with me?
Yeah.
Don't pay attention to the words. If I were you, I would just right now just say non-specific delirium signs and symptoms. That's what this is. That's why I put it in blue overhead. Anytime you see a patient that has what looks like delirium, but then they complain of headache and fever, they're dealing with encephalitis. Because delirium, unless it's caused by infection itself, does not normally have fever. Okay? Delirium is an acute confusional state. Fever is not part of it. If fever and headache are part of delirium, then you're thinking this is encephalitis. Okay? Because it's a cortical dysfunction. A febrile cortical dysfunction with a headache is almost always encephalitis. Okay? So even though I gave you this, to let you know, what you will read in the books is this. But what you really need to understand is that headache with fever and delirium is encephalitis. Okay, and you already know what delirium is. And you remember when we're talking about delirium, infections was one of the things we put there. Right? Okay.
Dr. Mark,
Yes.
So how would you differentiate delirium caused by an infection versus encephalitis?
Invariably, delirium caused by infection is encephalitis. You understand what I'm saying? Whenever an infection causes delirium, it's because the brain tissue is inflamed, is involved in that infection. Okay? What I thought you would have asked me, how then do you differentiate between encephalopathy and encephalitis? In other words, how do you differentiate between a metabolic delirium versus an infectious delirium? So how would you know if somebody is having liver failure with hepatic encephalopathy versus encephalitis? That can be difficult. Because there could be other reasons for fever in somebody with liver failure. For instance, somebody has SBP. You know what SBP is, right? Spontaneous bacterial peritonitis. They could have fever. And that person may not come to you because they're so used to having pain in their stomach all the time that they will wait until the peritonitis is really far advanced. And then they go into hepatic encephalopathy because now they have nausea, vomiting, and they can't eat. Right? So they come obtunded, liver enzymes are high, and they're febrile. You have to calm down, take a good history for the sequence. Right? In somebody with encephalitis, the headache will be first. The fever will be next before you get the delirium. Whereas in somebody with, say, hepatic encephalopathy and say with spontaneous bacterial peritonitis, the gnawing abdominal pain would have been there for like a couple of weeks. Then the anorexia, vomiting, and then the loss of consciousness will be more like in the recent days, few days. Are you with me? That is why when you're taking history from patient, it's extremely important to establish the chronological sequence of the major events. The events you're going to base your clinical diagnosis on, you must have a good chronology for them. Because that timing is everything in clinical evaluation. Okay? Unfortunately, I did not teach your patient standard database, but I used to have a lecture where I talked about the importance of chronology. We always start from the most recent to the most remote. And when you list it like that, as a list, many, many times, you will see what came first. So take a look at this. So encephalopathy is a metabolic delirium, right? Fever is uncommon, headache is uncommon. But in encephalitis, look at it. Fever and headache are very common. Both of them can give you altered mental status because that is what delirium is, right? Focal neurologic deficit, you will never find in metabolic encephalopathy. You won't. But you can find it in encephalitis, especially if it is fungal. Right? Are you with me? Seizures. You can find seizure in either of them. And of course, when you do blood test in encephalopathy, you don't find an increased white count. No, because encephalopathy is not an infection. It's an encephalopathy. It's a metabolic condition, right? You don't find increased white count in CSF in encephalopathy, but you find it in encephalitis because almost always when there is encephalitis, there is some degree of involvement of the surrounding meninges. Almost always. Okay. And of course, MRI is often and almost always normal in encephalopathy, but may show focal anomalies in encephalitis. All right, moving on. How do you diagnose encephalitis? Again, neuropsychiatric symptoms in a febrile patient. Ipso facto. What does that mean? What does ipso facto mean? Oh, come on, guys. Okay, go figure. Common things occur commonly, as a matter of fact. Right? So if somebody, if a mother tells you that my teenage son, well behaved, no drugs, no alcohol, came in the house chasing his baby brother with a knife, saying he wants to kill him, and they sent them to, the police came, and then they said it was a psychiatric disturbance, and psychiatrists did not find anything, and now they're following up with you. What would you think is happening? Huh?
Toxicology screen.
Good. Drugs. What else? Encephalitis. When encephalitis affects the temporal lobe, frontal lobe, it behaves just like a dementia in that particular area. And people can become aggressive and do crazy stuff. Okay, but one thing you must know before you make that diagnosis is fever. Very important. That's why I said neuropsychiatric symptom in a febrile patient. That is what will point you towards encephalitis. And of course, there might be other things. Past medical history. If your patient is HIV/AIDS, malignant, they have cancers, or they are on immunosuppressive therapy for organ transplantation, again, that will point you to a different set of causes, right? Like fungals and stuff like that. If somebody has had travel, they just came from a cave, or they visited Yankari, or they went to raid some bat cave all over. You examine the patient, meningeal signs with focal neurologic deficit. Again, acute neuropsychopathology following a brief viral illness. So you should remember these things. Sometimes the encephalitis can follow the viral illness by about 2 weeks. Okay? The interesting thing about encephalitis is that we always suspect it, we never really diagnose it. Why don't we diagnose it? Because to diagnose it, you have to do these titers. These titers are time consuming, to start with. Most plans don't pay for them. And by the time you get the result, the patient is dead or recovered. Okay? And then if you do lumbar puncture, you can see, depending on the degree of involvement of the meninges, you can see abnormal CSF cell count. You might see abnormal glucose level. You might see elevated protein. And if you suspect it from the history, you send for special testing, especially if you're thinking about syphilis. You do all these special tests, VDRL and the confirmatory test. And then you can do PCR. We can do all this, but it's encephalitis. Most of the time it's viral with self-limiting. The madness will be over very quickly, and everybody will forget it happened. Okay? The only time you worry is when there is masquerading as encephalitis, when there is something more deadly going on. Okay? So nobody bothers you with this. As a matter of fact, I've reviewed your questions, thousands of them, literally. I'm yet to see a case of encephalitis. Okay. So I'm just giving you this for you to know. You probably said somebody will ask you this in your exam. No, it's not a knowledge. The closest I've seen is when they need you to know how to diagnose neurosyphilis. And you know that for neurosyphilis, you only need VDRL on CSF. You don't need to confirm. Because this antibody that this other test, this fluorescent troponin antibody test is based on, does not cross the blood-brain barrier. So if you're thinking neurosyphilis, you always do VDRL on CSF, or you do PCR. Okay? I think that's important for you to know. Okay, herpes encephalitis, you see where it goes. When you do MRI, you can actually see the intense signaling. How do you treat it? Again, look at it. There's nothing. You treat the cause if you can identify it. You stabilize the patient and you give symptomatic treatment. It's ABC, right? Airway, breathing, because the patient could lose consciousness. Airway, breathing, circulation, support them, feed them, catheterize them, right? Foley catheter to get urine, feed them so they don't starve. Control fever with acetaminophen. Control seizure with dilantin. Is acting out, give him Haldol. For intracranial hypertension, sedative, give him steroid, give him mannitol. You know all this already, right? There's nothing new here. And if you're able to identify a specific risk factor, say the guy just came back from Africa, and you think this could be malaria, give him quinine, right? Give him amphotericin B if you think it's a fungal disease. Penicillin G for syphilis and Lyme disease. Acyclovir or ganciclovir for herpes, right? Then if you think it's autoimmune, as in Rasmussen's, you might do immunotherapy. At the end of the day, you will do one of these, depending on the history, but the history is what will guide you. Okay? I think it's important that you know that we've used acyclovir for so long now that many herpes viruses are actually resistant to acyclovir. The only medication that you can use for acyclovir resistance is foscarnet or vidarabine. Okay, that is so important for you to know. Okay, in practice, how do you prevent encephalitis? Well, avoid the exposure. Don't go to the place when you know it's infected. If you must go to Africa or Guatemala, carry a mosquito net with you or mosquito repellent. Personal hygiene, wash your hand and cover cough. Anthony Bourdain used to go to places and eat all kind of stuff. And then he committed suicide in a London hotel. You would have thought he was doing so well. Pre-exposure, sometimes you have to go because it's related to your job. you can actually get pre-exposure prophylaxis. So you're loaded with antibodies against the virus before you get there. We do that for rabies and malaria. We don't have vaccine, but we have mefloquine. And mefloquine is quinine that you can take about 2 weeks before you travel, and you take it while you're there. And then when you come back, you take it for 4 weeks. The truth is that most Africans will not take malaria prophylaxis from you. I am yet to convince any of my African friends to take malaria prophylaxis. And the reason they don't take it is because they ask me, do you take it? And I said, no. Then they say, why? And I say, you know, the reason I don't take malaria prophylaxis is because I'm African. I'm a son of the soil. There should be nothing in that soil that should hurt me. If I've been here so long that I've lost my identity and relationship with the soil, I need to be reintroduced to the soil. And that was what happened to me, because when I came here in 1991, I couldn't go back home until 2002, almost 10 years. And I was going to go, and somebody said, would you take malaria prophylaxis? I said, no. I went there. By the third day, I was having diarrhea. I kept eating and drinking like everybody else. I had diarrhea throughout the 2 weeks. And I came back on the third day, and I was alone this time. In my little studio, a temperature of 106. 106. I was having shaking. I was like, this is not gonna kill me. This is malaria. You know what I did? 2 o'clock in the afternoon, in this summer, I put on my tracksuit and I started jogging with a temp of 106. You would ask me, why did you do that? I'll tell you, there was a simple reason why I did it. I was having fever, right? I was burning up. If I generate more heat, the body will have to do something. The body preserves itself all the time. Okay? Don't give this to anybody as an advice. Okay? The body preserves itself all the time. So what, you know what? When I went out, I jogged for 30 minutes, came back and took a bath. The fever broke, and I was fine in 24 hours. But that first 12 hours before I went out, because it started about 4 o'clock in the morning. That was my introduction to malaria, because I had lost my immunity because I've been out so long. Do you know now I don't take anything. I don't use mosquito net. I go everywhere. I eat everything, and I'm fine. If I had taken mefloquine 10 years ago, I would need to take it every time. There is I personally feel like I've lost something. You know, I've lost my connection to the continent. And I couldn't live with myself. So, and the same thing happens to many people from different places. You've been in the US for a long time, you go home, why do you think many African countries got their independence from the British? Because malaria was killing the British. When they get malaria, it doesn't stop in their blood. For some reason, the systemic inflammation makes their blood-brain barrier so porous that the parasite can cross the blood-brain barrier, and they get what is called cerebral malaria. And that's the killer. And nobody knew what malaria vaccine was. So all of their Lord Regards were dying. And they were like, leave these Africans alone. That's how they came. And the same thing in many of these South and Central Americans, and if you look at the French colonies, something in the soil that was protecting the people was hurting the immigrants. You know? And I'm sure if you look very well in the history of America, you'll notice that there was something here that was also very discouraging, but those people that founded the country had something, that resilience that I was talking about. Anyway, That's the story of malaria. Screening, you think TB, you screen for it. You think VDRL, syphilis, you screen for it. Travel, you must go to Japan, find out the Japanese encephalitis. Any more questions, you can talk to Vinny. Vinny, are you from Japan?
No,
Where are you from?
not Japan.
Not Japan. Okay, you can talk to, for not Japan questions, you can talk to me. Oh, Vietnamese. Oh, sorry. I don't know, I have a problem. Hey, you know what?
Emmy, you can talk to
Emmy. Okay, for all official questions around. Sorry. You know, and then MMR question? Okay, MMR is important for all of these reasons as well. So this is encephalitis. We still have quite a bit. You want a break?
Yeah.
Okay, so take 5 minute break and then we'll finish in the next hour. Hey.
I was talking to my mom because we have to do a presentation for psychosocial,
Yeah,
like health stuff. My mom was born in Papua New Guinea.
she was born.
Papua New Guinea.
Okay,
During the time that they were getting their independence
okay,
from Britain.
okay.
And she was like, a big thing was malaria.
Yeah. Oh yes, malaria was a big deal. Yeah, in fact, the independence of many of those African countries is because of malaria.
Yeah.
Because the natives were immune to it,
Yeah.
and the British were not.
I thought that was interesting.
It is the reason that I feel strongly that
I think that's why. You think that's a big part of it?
it is. It's not that I
Because
think
they couldn't live there.
they couldn't live there. The reason
You know, my
America-
mom was born there, so I wonder if like, no, because she wouldn't have it in her genes. Her parents are Australian.
She's been out of Papua New Guinea for so long.
Yeah.
Does she go back often?
No, when she was younger, when we were still in Australia, she would go
Okay.
and visit.
That is why I always go. At
Yeah.
least once a year to get re-inoculated.
Yeah, that's smart.
Because if you don't, I just have a sentiment that why would I lose?
No, you wouldn't.
Yeah, that's like
Yeah.
it's like losing your badge.
Yeah. You think in Australia the natives are Aborigines, but they
Yes.
don't have that there, right?
Oh yeah, the Aborigines are the toughest human beings in that part of the world. Yes,
I know.
because they kept their old ways of life and they survive in.
They live in like the hottest.
Yes, and that is why whenever
And it's still
civilization.
like that.
Yes, till tomorrow.
Yeah.
They call it the bush, like the Bushmen of the Kalahari as well. You know, once civilization comes, they move further into the bush.
Yeah, but
Because-
no one's gonna touch the
Nobody-
central because none of us can live there.
No, exactly.
It's too hot. Okay, that's interesting. I like that.
Hey.
What was this ipso facto?
As a matter of fact.
As a matter of fact, I never knew that. Okay. I was like, what is it?
Google it. Google it.
Google it? Okay.
Tell me. Tell me what Google says. Ipso facto.
Yeah, by that very fast or act.
Exactly.
Oh, okay. I'll wait.
On your insurance card?
Do you like that guy?
Does it explain why? Because it's because I know when I had an issue. Some people asked Holly. Okay. Exactly. You know, I'm smart about these. I make my own. It is cheaper. It just requires planning.
But instead of that, the piano, and not the one that is
Already crumbled?
yeah, already covered, yeah. So, you can add whatever you want.
It's so cold in here. Yeah, I just can't get rid of this cough. I don't know why. Like, no matter. No, yeah, I don't know. Like, it's been about like a week now. Yeah. So I promise I'm not contagious. Well, I would have got it by now.
Pretty sure I would have done it because you and Pam are very close to you.
Yeah. She
Sit
like
close to me
she
and
like
Pam
quarantined me for like the first like 3 days. I wasn't allowed anywhere except for my room.
Oh, come get my hair. I'm trying to show the camera. My hair goes like.
I just wanna like go. I know. Okay, like, yours was. Yeah. I think I got it all good.
I got it from Zoom. I think it was from Zoom. I don't know. I got it from Black Friday.
Donut.
Oh, yeah.
You only got one
It
left.
wasn't. Yeah, it wasn't.
Don't deny yourself good.
It was like. I just remember I got it on Black Friday.
That is true.
We just didn't. Oh wow.
Yeah. Good extra walk. I'm gonna go to Costco, so that's extra calories burning. Walking around the store. So. No. I usually don't get this every day. No. I mean, I never really like.
Okay. Where is everybody?
They're just trying to get some sun. It's cool in here. I'll probably come back.
So we're going to talk about brain abscess. You know, generally speaking, when you talk about encephalitis, we're just talking about inflammation. And in pathophysiology, remember, how does inflammation always resolve? You can have complete resolution, or you can have suppuration, or you can go into granuloma formation, right? And then go into fibrosis. Those are the three ways in which any inflammation will resolve. So when you have encephalitis, like all inflammation, it could resolve completely and the brain will recover completely, or it could form pus. So brain abscess is a focal suppurative inflammation of the brain. I'm gonna lock everybody up.
Do it. Damn.
Because it was only a 5-minute break.
5 minutes, time is relative.
Chris isn't gonna.
That's what happens when you have too much sugar on board.
I feel so bad.
Okay, so brain abscess is, like I was saying, I mean, you've seen boils, right? When you have a little boil, right? You see it first red, painful, elevated area, right? And if you put hot, warm compresses or take antibiotics, and it could go away completely, and nothing else happened. But if you don't, say you left it alone, you keep watching it. After a while, it will become brownish and it will point. And then after a while it will burst and the pus will come out. So inflammation, generally, they can resolve completely or they can form pus, suppuration. Brain abscess is encephalitis that resolves by suppuration. So when encephalitis resolves by suppuration, you form brain abscess. And generally speaking, brain abscess is usually bacterial, but it could be fungal or parasitic. But clinically, we divide brain abscess into two, acute or chronic. Acute, usually in immunocompetent individuals, chronic in immunocompromised persons. So when you have acute brain abscess, it is usually bacterial, and most of the time is strep, staph, haemophilus, the gram-negative, and the bacteroides, the anaerobes, okay? Those are the common causes of brain abscess in healthy people. When you find brain abscess on a chronic basis in anybody, it is usually due to Listeria monocytogenes in cancer patients. It could be due to TB in HIV, and in organ transplant patients, it is usually due to nocardia. Okay? And then when it is non-bacterial, it's usually fungal, like I said, Aspergillus, Cryptococcus, Candida, and parasitic as in Toxoplasma, Tinea, Entamoeba. Now, the truth is this. The one that you really need to know about is the acute bacterial. Because invariably, most of the time, what you find out is that you will find a patient with brain abscess. When it's due to any of these, you never can be too sure. Okay? And invariably, you have to do what is called a stereostatic abscess biopsy, actually, to get a sample of it and culture it to identify it. But for practice sake, I will ask you to match a number of these: Listeria with cancer, TB with HIV, nocardia, especially with organ transplant. Okay, and I won't bother you with the rest of that. I want you to remember that I'm not giving you a new list here. Everything here we've talked about. Okay? Listeria and immunocompromise, we already talked about. The only new piece of information here is nocardia in organ transplant patients. Okay? When should you think about brain abscess? Whenever you have a patient with a risk factor. Because 50% of the time, 50%, that is half of the times, brain abscess is as a result of contiguous infection. Ear infection, mastoid infection, sinus infection, dental infection, tongue piercing. So you see a teenage, not even teenager anymore, we're all living like we're teenagers. But if somebody will go and pierce tongue, right? Why do people pierce their tongue? I don't know. But you pierce tongue, and 2 weeks later, they come with headache, and they have fever, and the headache is not going away with Tylenol. Think brain abscess. Okay, because it's common. I told you about my friend in medical school that died because she pushed pimple. And that's why I told you, stay away from pimple between the angle of the eye and the angle of the mouth. Because those veins, they drain directly into the sinuses, the venous sinuses in the brain. And once you get one bacterium into that sinus, that's all you need. You end up with big deal infection. She died, right? And she pushed a pimple, that's all she did. You know what happens? You see a pimple, right? It's a swelling. It's not pointing. When it's pointing, that tells you where it's going to burst from. But many times, ladies push on these things before it points. The truth is, just because you don't see it pointing on the outside does not mean it's not pointing on the inside, right? So when you put the pressure, it might go away, but that is because it's busted on the inside. And if there happens to be a blood vessel, all you just did was empty a bunch of staph aureus into the venous sinus in the brain. You're not going to survive that, right? So many times, brain abscess is from contiguous infection, dental infection. You see somebody with dental abscess, even root canal, professionally done, can predispose to this. That is why you notice that dentists generally, depending on how bloody they're expecting your dental work to be, they will give you antibiotic coverage to avoid this type of spread. Then about 30% of the time is hematogenous spread, like congenital heart disease. Tetralogy of Fallot can be complicated by brain abscess. Endocarditis, lung infection, skin infection, especially people that use intravenous drug abuse, right? And then the rarest one is 10% by direct inoculation, a stab wound to the head or gunshot wound to the head, or even neurosurgical procedures, right? Like the VP shunt we talked about earlier. And the other 10%, you will never find out why. Okay. You've seen this before, right? When we did ENT, I told you about cavernous sinus thrombosis, right? It is usually the intermediate stage between paranasal infection, dental infection, and brain abscess. That is why this is a major medical emergency. Whenever you see evidence of cavernous sinus thrombosis, and it's so easy to identify, high fever, periorbital swelling, chemosis, that is the key thing there. Chemosis and periorbital edema. Very important. Periorbital edema you can see in orbital cellulitis. You don't see chemosis. Chemosis is conjunctival edema that makes the black of your eye looks like a hole because the conjunctiva is so swollen. You begin to see a depth of the black of the eye. You understand what I'm saying, right? When I look at you from the side, the most frontal part of your eyeball I can see is your cornea, right? That's what, if I look at you from the side, that's what I'll see. In chemosis, cornea is deeper because the conjunctiva rises above it. So you look at the cornea is like a hole because the conjunctiva is swollen. Okay, that is what is called chemosis. Once you see that, you don't fool around with that patient. You send that patient to the hospital. They need antibiotic, they need surgical decompression, because if you don't, they will end up with brain abscess and they may not survive. Okay? And I've told you about this before, so I'm not going to repeat it. You just need to know cavernous sinus thrombosis. And again, clinical manifestation of brain abscess, it depends. You see, if the abscess is tiny, part of an encephalitis where it's suppuration with surrounding encephalitis, or you may have maybe just headache, fever, and focal deficit, depending on which area of the brain is affected, right? Then you can actually begin to form more abscess. As you form more abscess, you get intracranial hypertension, right? So that's another way it could present. As the abscess expands, the bacteria begin to invade surrounding brain tissue, so you end up with an abscess surrounded by encephalitis. And one of the worst things that can happen to you is for the abscess to rupture into the subarachnoid space. And then you end up with meningitis. Okay, so why did I choose to give you this picture? Because the clinical manifestations of brain abscess therefore depends on the location of the abscess, the size of the abscess. Right. If it's a tiny abscess, it may not be any different from encephalitis, except that if the abscess is located in a critical spot, the patient may exhibit some focal neurodeficits. But if the area where the abscess is does not subserve any serious function, the abscess can be there and the patient will have no focal deficit. I've seen somebody with a bullet that went right through their head and they have no deficit. Don't ask me how, but somehow the brain is interesting. Okay? How do you diagnose it? CT scan, MRI is more sensitive than CT scan, but CT scan is always the first thing you do. It's cheaper, it's easier, right? Whenever you have brain abscess, surgeons will always look, and radiologists will always look for, they will always report sinusitis, otitis, or even mastocytitis. They will give you an associated lesion in the bone. Because remember what I said, 50% of the time, brain abscess is a result of contiguous spread. So most of the time, the radiologists feel the need to tell you, if they can, where they think the infection came from. And why is that important? Because if you know that it came from a sinus, that will guide the way you select your antibiotics. Okay, that's why it's important when they report that. How do you treat it? Yeah, I gave you a scheme. Bottom line, abscess anywhere must be drained. Okay? Whether it's ischiorectal abscess, empyema, brain abscess anywhere must be drained. You give antibiotics to treat the surrounding inflammation and infection, but you don't give antibiotics to treat abscess. What happens when you give somebody with abscess antibiotic? You convert the abscess into a tumor called antibioma. Okay, that is, and they test it a lot. I've seen it a lot in most of your questions. Don't ever make the mistake. Whenever there is an abscess anywhere, you must drain it. That does not mean you don't give antibiotics. You give antibiotics, okay? Because remember, if you have inflammation, the abscess is usually in the center. The inflammation is surrounding the abscess. So you will give the antibiotics to limit the size of the abscess. But ultimately, you drain abscesses. You don't give them antibiotic. Antibiotic therapy is not for abscess. Incision and drainage is the treatment for abscess. So this whole thing here is so many ways of telling you the same thing. So is there a mass effect? Well, yeah, mass effect means is the abscess expanding and compressing vital structures? Yes, you want to do urgent surgery, you drain it. If there isn't that, you look at it, the abscess, is it accessible? If it is accessible, yes, you drain it. Even when you're not certain that this thing is actually abscess or not, take it out and take a look at it. You understand what I'm saying? So this diagram looks big and complicated. It's not. Basically telling you that you think abscess, drain it. You're not sure, take it out and look. You don't watch abscess. You don't say, it might resolve. No, abscess anywhere, you drain.
What was it called, Dr. Martin's, a tumor that is converted after the
Antibioma. You know, instead of antibiotic, instead of TIC, you put MA, antibioma. You say, ID people that's what they call it, when generalists give antibiotics that convert an abscess into a solid mass. The reason it's bad is because an antibioma will not resolve. It will just stay there. And there is nothing, it's a collection of dead cells. It doesn't have blood supply. The body cannot liquefy and drain it. It just sits there. And it's a disservice. Because if you drain it, the cavity, the body will obliterate the cavity and the site will heal. But if you limit the ability of the body by converting the abscess into an antibioma, then there is no way it's going to resolve. Okay?
That's so crazy interesting to find out because I've actually worked with providers who like refuse to do like incision and drainage
Well, where?
or just like urgent care.
You can get away with incision and drainage if you don't do it with antibiotics, if you have superficial infections and separations. Because the truth, the reality is that when the infection is superficial and subcutaneous, the abscess is thin. So basically, because the abscess spreads out, the body can mop, the white cells can mop it up, and the macrophages can come in and lay fibrous tissue, and you get away with it. But when the abscess is in a cavity and like a globular form, where limited blood supply, you will convert it to an antibiotic. The place where I've seen it tested in the exam is in ischiorectal abscess. Ischiorectal. Yeah. So when you have an ischiorectal abscess, you have to drain that one. You cannot give antibiotic and expect to get away. Because even if it goes, if you give antibiotic and you convert it to an antibioma, you can create an obstruction to bowel movement with antibiotic. Yeah. All right. Like I said, it's not that you don't give antibiotics. In fact, you give antibiotics and you give it for a long time. Look, 6 to 8 weeks antibiotic course. This is the kind of patients you put in a PICC line. And you send the nurse home to give antibiotics after you have drained it, not in place of drainage. You have to drain the abscess.
So you drain and then start the antibiotics?
Yes. Remember, like I said, remember when we talked about infarction? You said the infarction zone is in the center, injured zone is surrounding it, ischemic zone is the outer layer. The same thing with abscess. When you have an abscess, you have this pus in the center, surrounding it is the inflammation. So you're giving the antibiotics for the surrounding inflammation, and you have to drain the abscess in the center, so you can collapse that cavity and give the patient what they need.
Is this specific just to brain abscesses or abscesses as well?
This is, what I just told you is for abscesses in general. I'm using what I'm saying to break down this complex figure for you. It's not as complicated as it looks. You always drain. When you drain and how you drain is what matters, right? Again, medical, broad spectrum antibiotics, and if the abscess is big enough that is raising the intracranial pressure, you may have to put in intracranial pressure measures like mannitol, monitors, and stuff like that. Okay? Neurosurgical drainage, again, stereostatic aspiration. And if stereostatic aspiration does not do it, you might need to actually do craniotomy, borehole, they call them, and surgical excision. And if the mastoid is the source, you take out the mastoid air cells in the surgery called mastoidectomy. Okay? Good. Now, that is all there is about encephalitis, meningitis, and brain abscess. We're going to repeat exactly the same thing now for the spinal cord. Right? And you will see that we will be repeating ourselves, but the only difference between spinal epidural abscess, myelitis, is the symptomatology. Instead of having altered level of consciousness, fever and headaches, you will get muscle weakness, bladder and urine bladder and fecal incontinence. Upper motor neuron signs below the lesion, lower motor neuron signs at the level of the lesion. So even though it looks like we're talking about a lot of things, if you remember all those things we talked about here under neuroevaluation, just only the names are changing. So spinal epidural abscess is a suppurative inflammation of the spinal epidural soft tissue. Simple. What causes it? Look at it. Spinal surgery or trauma, spinal instrumentation. It's like what we said, the 10% for brain abscess is direct inoculation, right? The same thing happens here. Spondylitis and spirogenic suppurative. What are the causative agents? Again, pus is usually formed by staph. aureus, staph epididymis, or pseudomonas in patients that are some specific patients, not necessarily immunocompromised, but patients like diabetic patients, and IV drug abusers. What is that? IV drug abusers are exposed, they are at risk for pseudomonas, and then you have Mycobacterium tuberculosis. These are the agents. The most important ones I want you to remember is Staph aureus is the most common one. When surgical instrumentation is involved, it is usually Staph epidermidis. For instance, you know patients that go for spinal injection, chronic low back pain. That's why I don't send my patient for spinal injection, because you can actually carry the Staph epidermidis from the skin directly into the spinal canal, okay, and create spinal epidural abscess. Okay. Again, how does it present? Look at it: back pain, fever, and neurodeficit. That's exactly what it is, right? Fever is what makes it unique. Back pain is not. The fever and the neurodeficit is what makes it spinal epidural abscess. Otherwise, it could just be chronic low back pain, right? Because you can get back pain and neurodeficit with herniation, disc herniation. You can, right? You did orthopedics, right? You can get back pain and weakness with just disc herniation, but you won't get fever. So if somebody presents acutely with back pain, weakness, acutely within 2 weeks, you're more likely to be dealing with a spinal epidural abscess. But if somebody presents with 6 years history of chronic low back pain, and now 6 days history of weakness and numbness, you know you're probably dealing with a disc herniation. Do you understand what I'm saying? So these things that I give you, back pain, fever, neurodeficit, yeah, they are for spinal epidural, but you'll find them in many chronic low back pain conditions, except the fever. And I told you exactly the same thing under encephalitis. Fever is the key. And then the signs, you will see local inflammation, pain, tenderness, swelling. And you remember what I told you, when you have a lesion at the level of the spinal cord, say T12, everything at T12L1 will show sign of lower motor neuron signs. And everything below that will show sign of upper motor neuron signs. And you remember what those signs are, right? Okay, we'll mention it as we go. But I need you to, this is so important. I found this key muscle thing in one hospital neuro center, and I think it's really cool. Right? It tells you the muscles in the upper extremities and lower extremities and the roots of the nerve that supplies them. You know, so say for instance somebody has a spinal epidural abscess at L2. So you find out that the hip flexors will be very weak. The patient will not be able to flex their hip. But the knee extensor will be okay, and the reflexes will be hyper, because that will be below the lesion. So you will be taking out the upper motor neurons that are on their way to L4, L5 to connect with their lower motor neuron. Whereas at L2, you will be destroying the lower motor neuron at that level. So generally speaking, for spinal cord lesions, at the level of the lesion, the muscles will show sign of lower motor neuron lesion. So there will be atrophy, fasciculations, hyporeflexia, and all those. But below the level of the lesion, who is that? Do you know that person? Oh, they gave him tours. We're not museum specimens. Move on. Right? So, below the level of the, it's rude for you to be people in the classroom and looking at people like that. Just those are the class, and then just move on. When the leg, yeah. Lots of museum. Okay, so remember that, because many times in exam situations, they will paint a picture for you, giving you lower motor neuron signs and upper motor neuron signs in specific groups of muscles. I've never seen it in your exams in neurology, but I think it's fair. It's a fair game to give you signs of upper motor neuron and lower motor neuron at specific levels of the spinal cord to help you determine where you think the lesion might be. I won't ask you because I think it's a little bit much. I didn't even ask that as an internist, but who knows? With all this technology these days, people are required to know more and more. So this is, I think I've lost my life. Okay. So you see, when you do the MRI, you see the abscess, contrast, without contrast, you see right there. It's a very easy thing to treat. Again, you will drain it. But how do you tell it apart from a regular low back pain? How do you tell it from a regular low back pain? I saw this thing over here giving you causes of what they call acute low back pain and chronic low back pain. And generally speaking, in medicine, if it is under 3 months, it is acute. If it is more than 3 months, it is chronic. It applies to kidney disease, whatever. Generally speaking, when it's under 3 months, we call it acute. Over 3 months, we call it chronic. So that's what they said here. And they gave you all kind of causes. The reason I cut this and I put it here is because regardless what you're seeing here, this needs to be in your list of differential diagnosis. Okay? So if somebody asks you, so this patient has low back pain and weakness of both legs, what the differential diagnosis? Must remember everything here. Right? But how do you then work the patient out? Okay, good. Spinal pain. Yes. Spinal pain. Back pain, right? Progressive neurodeficit. Yes. Got a problem. You need to do an urgent, emergent MRI. ESR and CRP, they are evidence of inflammation. Okay? That thing on the MRI could be a tumor. The way you respond to a tumor and an abscess is not the same. For an abscess, you're more in a hurry versus a tumor. Because a tumor, you have to biopsy it. Decide, is it a primary tumor or is it secondary tumor? And if it is a secondary tumor, you're going to have to start looking for the primary, right? So a mass in the epidural space, in the spine, it could be a tumor or it could be an abscess, but they're not the same thing. An abscess, you have to move much faster than in a tumor just because of the nature. All right. So that is why it is recommended here that you kind of do ESR, erythrocyte sedimentation rate, or C-reactive protein. These are evidence of inflammation, okay, that will support the diagnosis of an abscess as against the tumor, right? With fever, risk factors, neurodeficit, yes, that is more suggestive that this could indeed be an infection. Again, you want to do an urgent MRI, okay? No, look for other causes. They're over here. And then you walk invariably, what do you do here? X-rays. X-ray is negative. CT is negative. MRI. MRI is negative. Pray for the patient. Okay. Spinal epidural abscess is a medical emergency. I can't say it enough. Spinal epidural abscess is a medical emergency. And pay attention. How do you recognize it? It's not from paralysis. It's not from the pain. It's not from the paresthesia, even though they are present. Because those could be present in simple disc herniation. It is the fever. It is the fever. Don't forget that. In all these neurodeficits, fever is what points you to a bacterial infection. And you really need, I'm hoping that I'm emphasizing this, you're getting it. You need to be like, look for fever every single time you're looking at somebody with a neurodeficit. Because fever points you in a specific direction and you'll be more helpful to the patient. How do you treat it? Again, you drain it, antibiotics. When do you do it? That is what differs. Because invariably, when you have epidural abscess, you have associated infection of the bone. That's why he's talking about spondylodiscitis and osteomyelitis, involvement of the disc and involvement of the bone. Once you form abscess, you must decompress the spine. You must decompress the spine. How you triage it, how you get to decompression depends on where you are, right? But ultimately, abscesses must be drained. Okay? I don't pay too much attention to these figures because this is the way some hospitals did it. That does not mean that is the way every hospital will do it. Every hospital have their different protocols. So I use this just to, again, tell you that whenever there is abscess, you have to drain it. When you drain it, how you drain it, is what differs from different centers. Okay. And that is not, most of the time, it's not your decision. It's someone else's decision. You just need to understand that drainage is indicated and get the right team on board. Okay? You know, whenever you have spinal epidural abscess and it's been drained, there are two important complications that they are unfortunate, but they do happen. One is spondylitis. That means the infection went beyond the epidural space to involve the vertebral body. And the other is it went deeper on the inside and involves the arachnoid layer. You know what this causes? Arachnoiditis gives the patient permanent, persistent pain. There's nothing you can do about it. They're going to have pain all their life. And there is nothing, not even narco will change that. You know what happens with spondylitis? The spinal column will collapse. You've seen people, they call it hunchback. You've seen hunchback, right? Hunchback is as a result of collapse of the spine. It can come from rheumatoid arthritis, spinal arthritis, but a very common complication of spondylitis, where you have inflammation of the vertebral body, is that collapse of the spine. It's terrible. I saw a man one time that walked into the clinic like this. You know, I mean, all his life he has to walk like this. I never want to see where he's going. It's like this. And then he carries a cane, and I was like, my goodness. Even walking erect is not guaranteed. Look at this man, and he has had it in his 40s. And by the time I saw him, I don't remember where I saw him, but I cannot forget that picture. He was just, he's like, he was in pain 24/7. And I just couldn't, for the life of me, understand how that man lives day to day. Those are the conditions you need to be aware of. I'm going to move on to multiple sclerosis. This is very important. I want to make sure I have some time to talk about it. Anybody seen a patient with multiple sclerosis? Yeah, it's so common. Everybody has seen somebody that knows that. It's the most common, okay, by the way, I'm switching gear, right? So I've been talking about infection, inflammation with causative agents, right? I'm going now to autoimmune causes of inflammation in the CNS, okay? And the most common one is multiple sclerosis. It's the most common autoimmune demyelinating disease of the central nervous system. For some odd reason, it is rare the closer you are to the equator. The farther you are from the equator, the more of it you have. So when I was in Nigeria, I never saw multiple sclerosis until I came to America, right? Away from the equator, you see all these red zones, that's where you have it, right? So that north-south gradient incidence from the equator, we don't know what causes it, but something about it, and so on, maybe, I don't know. Female preponderance is more common, twice as common in female. We don't know what causes it, but we know it runs in families. So if you have genetic predisposition, but not everybody that has genetic predisposition ultimately develops it. So you kind of have to have a genetic predisposition, and you have to have some kind of environmental trigger that will precipitate it. Okay, and we know some things that will precipitate it: viral infection, psychosocial stress, toxic occupational exposures like lead, even cigarette smoking has been implicated in it. It is a very, very devastating disease because, see, it affects people between the ages of 20 and 40, in the prime of life. You know, you gather your wealth between your 20s and your 40s, then you live your life between 40 and 60, then you spend the rest of your life cleaning up the mess you created in your 20s and 40s. That is how it is, right? See, multiple sclerosis takes you out in the prime of your life. Talk about all this. Look at the difference. 110 to 140 cases, 100,000 above the equator, compared to 57 to 78 cases per 100,000 below the equator. Even the United States, the up north and down south, if you're going to see multiple sclerosis in California, many times people had come from up north. Okay. We don't know why this is the situation, but you need to know it does exist. If anybody would ask you anything, it's about this north-south gradient worldwide and locally in the United States as well. Okay, there's a gradient. It tends to be, prevalence tends to be higher in north of the equator, north of the country.
Mr. Martin?
Yes.
Why is there a worse prognosis in males?
I believe it's late diagnosis, because it's more common in female where our antenna is off in a female to quickly diagnose it. But in a male, we'll call it everything else until it's too late. You know what I mean? Invariably, do we really treat multiple sclerosis? We don't. We don't know how to treat it. You will see very clearly. So I believe it's the late diagnosis in male that will cause that. Okay? Now, we don't know what causes it, but people have come up with all kind of theories on why they think it happens. They say the blood-brain barrier breaks down. Okay, fine. So you have inflammation. Because of the inflammation, the blood-brain barrier becomes porous. White cells get into the brain. They shouldn't be in the brain. And then the patient recovers from the inflammation, and the integrity of the blood-brain barrier is restored, and the T cells are trapped within the brain, and they can't come out. And because T cells always produce cytotoxins, those cytotoxins begin now to attack the neurons. That's one hypothesis. Has it been proven? It hasn't been proven. It's a hypothesis, sorry. And then they say, no, it's an autoimmune problem. The immune system attacks the nervous system, forming plaques and lesions. Commonly involving the white matters? Maybe, maybe not. I don't know. And it's called the autoimmunology hypothesis. Then there is the inflammation. Regardless what is causing it, one thing we know is that multiple sclerosis is a demyelinating disease. Period. something happens and the nerves lose their myelin sheath. That's all we know. How it happens, your guess is as good as mine. How does it present? Again, it depends on which part of the brain is affected. Look, 70% of them is just numbness and tingling, right? Dizziness, cognitive dysfunction, emotional changes, hearing loss, pain, fatigue. Any symptom of the central nervous system can be a symptom of multiple sclerosis. It's so non-specific, it's so generalized, right? There is no specific order to it. At least when we talk about spinal epidural abscess, we talk about upper motor neuron signs below the lesion, lower motor neuron signs at the level of the lesion. In multiple sclerosis, nothing like that. It involves autonomic nervous system, it involves sensory neurons, it involves motor neurons, patchy, indiscriminate everywhere. Today, the patient might tell you, 3 months ago, I was feeling pain in this finger. And that lasted for about 2 weeks and it went away. And today I can't clench my fist. Why? Because I can't find strength. What is this? That is not a stroke. Because why did it go away? Why is it not? And that was a sensory symptom. Why is he not able to clench his feet? That's a motor symptom. And then you now do orthostatic. You find the patient is orthostatic, positively orthostatic, like this. Whatever this disease is, it's so non-specific. It doesn't affect any one region or any one system. It's affecting all the brain tissue, sensory neurons, motor neurons, autonomic neurons, everywhere at the same time. Think MS, think MS, think MS. No other disease does that. That don't. Okay? So that's why you notice that it's all this stuff. And then there are some things that I'm sure they like for you to know. There is something called Uthoff's phenomenon and Lemit sign. Uthoff phenomenon is something you find in multiple sclerosis, where the patient goes into the sauna, or like MS patient in New York right now will have a lot of relapse because of the heat. So Uthoff is the worsening of the symptoms and signs in hot weather, in sauna, with fever, or even with exercise. So you see somebody, they say, okay, they have history of MS, and then they decide to participate in marathon. And then during the marathon, they will slump because the heat or the exercise can make their symptom worse. Okay? Lemit sign is you get the patient and you do a gentle tap on the back of the neck and you elicit electric shock, pain from the spine down to the limbs, just by a gentle pressure on the back of the neck, in flexed. The flexed neck, gentle pressure. You know the way we do punch tenderness for nephritis or paranephritis? That is just the equivalent of that in Lemit signs. Okay? So, MS, anytime you see any neurological sign or symptom in somebody between that age, 20 to 40, that is intermittent, comes and goes, you must think MS. All right? Now, because MS is so like non-specific in its manifestation, in order for you to diagnose it, you must have signs and symptoms that are suggestive, you must show evidence of inflammation, and you must show evidence of demyelination. You see what I said earlier? Signs and symptoms by itself don't cut it, because that can come from many other things, right? You have to show neurodeficit. You have to show that the neurodeficit is from inflammation. And not just that. You have to show that the inflammation is leading to demyelination. And remember, the reason the myelinated fibers differ from non-myelinated fibers is in their speed of conduction. The purpose of myelination is to accelerate conduction, right? So when the nerve fibers lose their myelin sheet, then they lose that electrical activity. So they exhibit reduced evoked potential You can test it in the visual nerves or the sensory nerves, does not matter. You will show evidence of reduced evoked potential. Okay? And then you can do MRI and you see plaques, plaque lesions. They know, radiologists know what it looks like. Now, how do we define inflammation for multiple sclerosis? I just need you to know that if you take CSF and you subject it to electrophoresis, this is the way it pans out. You have the IgG uniform band, and then you have the other protein bands, albumin, globulins, and all that, uniformly spread out like that. You know about electrophoresis, right?
Yes.
You know, it's taking protein and subjecting them to an electric field, and they migrate from pole to pole depending on their size and their weight, right? Okay. This is the way it would normally pan out in a normal person. In somebody with mild MS, they get these things called oligoclonal bands. So subset of IgG that band together, right? They call them oligoclonal bands, right? That is what you're looking for in patients with multiple sclerosis. So once you suspect multiple sclerosis, you generally send the patient usually to a neurologist. A neurologist will do a lumbar, schedule the patient for lumbar puncture, take the CSF and do this electrophoresis, looking for evidence of inflammation. In addition to looking for evidence of demyelination on the MRI, they're looking for plaques. You would have thought that that would have been enough to diagnose it, but it's not. Many, many times, even with signs and symptoms, evidence of inflammation and evidence of demyelination, we still misdiagnose MS. So this guy, McDonald, who's a neurologist, came up with this criteria for diagnosing MS. You don't need to know the specifics of it, because nobody expects you to carry it in your head. But you need to know that for diagnosis of MS, we need the McDonald criteria. And it's not very complicated. McDonald criteria says, in order for you to say the patient has multiple sclerosis without any doubt, they have to have 2 or more attacks. And when you do their MRI, you see 2 or more lesions. If you can do that, that is MS. But if your patient has had 2 or more attacks, but they have only 1 lesion on the MRI, then you have to demonstrate dissemination in space by waiting for further attacks and future MRIs. If, on the other hand, they have 2 lesions, but they have only had 1 attack, again, you don't have to wait for evidence of dissemination in time, by again doing more MRIs or following up for symptoms. So basically, you need, because MS runs a remitting, relapsing course, you have to show that the patient is having repeated attacks, and that these repeated attacks are coming from attacks in different sections of the brain at different times. That's what they call dissemination in space and time. And I gave you, it is described further here, right? In space, you're looking for areas, specific lesions, lesions in specific areas of the brain, like the periventricular, justal, cortical, infratentorial, spinal cord. You can spend your time on this if you want to. I don't expect you to memorize this. All I really need you to know is that for MS diagnosis, we need McDonald criteria, because we need to prove that the attacks are relapsing, remitting, affecting different areas of the brain at different times. And the way we definitely describe that is we have to show evidence of dissemination in space. In other words, which part of the brain, and in time. In other words, the patient recovering and relapsing at different times. So dissemination in space and time is what McDonald criteria is all about. Okay, moving on. So now you've diagnosed MS, what do you do? it's more trouble to, it's a lot easier to treat MH than to diagnose it. Steroids, that's it. Acute attack, you give them high dose, and I mean high dose steroids. I'm talking grams of steroids, okay? High dose steroids for 3 to 5 days, then you do a rapid taper. When steroids don't work, we do plasmapheresis. Only when steroids don't work. So you give steroids for a week, and nothing has happened, you do plasma exchange. The idea is to dilute the antibodies that are attacking the central nervous system, right? And somehow there is some evidence that vitamin D supplementation reduces the relapse rate. So you always want to make sure your patient has vitamin D levels at least. Some people say 50, some say 100. Normal is 30, okay? But you want to keep high level of vitamin D. Vitamin D is not a treatment for multiple sclerosis. It's not a treatment. But normal or adequate vitamin D levels reduce the relapse rate. Okay, so once you treat the disease, you optimize vitamin D levels to reduce recurrence. Okay? Ultimately, the patient is going to need a disease-modifying agent, and they have all kind of biologic now. I give them a list. I give you a list. The popular ones are Extavia. Extavia is very popular. Beta-seron is another popular. Avonex is there. These are all biologics. They're called disease-modifying agents that you can use in the treatment of MS. Yeah.
So in the block exam you gave us, the tertiary exam you gave us initially, you asked us a question about MS and steroids and interferon. So how would you know when to use which?
It depends really on the way the disease is progressing. These are decisions that neurologists make, right? Disease-modifying agents in MS, they are divided into biologics, like the antibodies, right? And then the immunomodulating agents. What you pick, the criteria for which you use which one, I don't know. I've never had to do that, right? But generally speaking, you identify, what you need to know how to do is to treat the acute attack, optimize vitamin D, send the patient on for disease-modifying agent. I don't know if I answered the question.
No, because that question, if I remember correctly, had steroids and had interferon in it. So how do you know, how do I choose which one is which?
Because I'm saying that interferon is a disease-modifying agent. Steroids is for acute attack. Right? So somebody has MS, they are weak and they're leaking urine, leaking feces. Steroids, high dose steroids, 3 to 5 days. They respond, good. You optimize vitamin D, you send them on for disease-modifying agent, which could be biologic or it could be interferon. Now, the same patient, you give high dose steroids, 3 to 5 days, it's getting worse. You don't do interferon because interferon is a disease-modifying agent. It's not for acute attack. You do plasma exchange. Now remember the question I gave you, the answer was plasma exchange because I think it was steroid refractory case.
It was, which of the following medications are used to decrease the frequency of relapses of moderate or severe attacks stemming from MS? The answer was interferon.
Was interferon.
Yeah.
What exam was that?
The last one we just did.
Midterm?
Oh, no, it's a review, the medicine review.
The board.
Oh, the board review.
Yeah.
Interferon was the answer for minimal. Oh, wait. Read the question again.
Oh, no, corticosteroids is the answer.
No, but he
No,
picked.
read the, could you?
What we did in class.
So which of the following meds are used to decrease the frequency of relapses of moderate or severe attacks stemming from MS.
Okay, and the options are?
Corticosteroids, interferon, cyclophosphamide, amantadine, and mitoxantrone.
And the answer was what?
I believe.
What's a biologic, you said?
In that list that you have there,
Interferon is the correct answer.
in that list you have there, the only disease-modifying agent there is interferon. Now, steroid is not used to delay attacks, it's used to treat the attack. Right? Vitamin D is used to minimize the rate of relapse. It does not do anything, we don't know what it does to the disease, but normal vitamin D levels reduce the frequency of attacks. So it's not like it modifies it in any way at all, right? What I need you to know in that question, the reason interferon is the answer is because interferon is the only disease-modifying agent in that list there, right? And what disease-modifying agents are given for is to prolong the remission of the patient, to keep the patient in remission longer, so you don't have to use steroids all the time. So whether it's interferon or it's biologic, they are disease-modifying agent. This is what you use to induce the remission. This is what you try to use to sustain the remission, but they don't abolish it. We don't have any cure for MS yet. As a matter of fact, some of these medications make the patient a lot sicker, right? So the way you know when to use a biologic is when your patient is not in an acute attack, but you want to prolong the remission. For acute attack, your patient is having an attack right now, is steroids. The attack is not getting better, you do plasma exchange. Right? Now you're able to knock off the attack, you want to sustain the remission, use disease-modifying agent. Okay? So steroid won't be the answer in that case. Vitamin D won't be, I don't even think, but if vitamin D had been that option, it would have been more difficult to tease out vitamin D, because somehow we know we give vitamin D because it somehow reduces relapse rate in MS. Okay? Yes. You know, in MS, we know what is going on. We treat neurodeficit, but they get a hell of a lot more that we can manage. Pain is a problem in MS. We give narcotics when NSAIDs don't work. Paresthesia, we give gabapentin to take out the nerves, to numb them, right? Sometimes they take out multiple segments in the spinal cord and they have spasticity, right? Because, spasticity is one of the signs of upper motor neuron lesion, right? So if somebody has an MS lesion, say at L2, they will be stiff, L3, L4, L5, and that's where your gluteus or your hamstrings are from. So they will be stiff legs. And then you have to give them things like baclofen or Xanaflex as muscle relaxant. Bladder dysfunction is very common. Sometimes the bladder is overactive, they can't hold their urine, they pee on themselves. They know they need to pee, and before they could get to the bathroom, the pee is out. Or sometimes the bladder is underactive, in which case you have to catheterize them. So they don't know when they are full, and they go into overflow incontinence, and then you have to give them catheterization. They get tired a lot as part of the disease, and you can give them stimulants like Provision or even Cimetron, right? Depression is common because, look, the disease happens in 20 to 40s, in the prime of life, when most people look forward to engagement and marriage and children and family, and then they realize they can't even hold their pee. That is not a good thing, right? So depression is definitely there. And then sometimes there is frank paralysis, right? And Ampera is one of these it's a very new medication, by the way, that has been shown to assist with difficulty walking. I'm giving you this as a reference material for practice, because I don't know where you end up. Bowel dysfunction is so common. All of this is symptomatic treatment. Laxative for constipation, diapers for incontinence. I've had this patient for over 10 years now with MS, and all I do is keep refilling Zenaflex and diapers and catheters. And sometimes I wonder, what am I doing? Why am I even getting paid for seeing this patient? Because I'm not doing anything for her. You know, it's a terrible, terrible disease to manage. What is this? What is this about? Okay, dextromethorphan. These are the ones for crying spells, right? They have that pseudobulbar affect. You remember what PBAs, pseudobulbar affect, where the patient wakes up and they start crying, and they can't tell you why they're crying. I've witnessed this firsthand in a very close friend. We're at work. You start crying. I'm like, why are you crying? She can't tell me why she's crying. She's crying, and sours everybody's mood. I'll stop doing what we're doing, and then she goes home. And then at times she comes and she's just happy. Like, what? You win the lottery or what? Why are you so happy? Just have these swings, and they can't even explain it. It's called pseudobulbar affect. It's not just in MS. Where else do you see that? Where? Where else do you see pseudobulbar affect? It's one of those dimensions, right? Man, you guys are like, it is expected. You're about near your limit now. This is summer, right? Yeah. We have talked. Everything is still pressed down and shaking. You're almost exploding right about now. But don't worry. Just remember that for your clinical year, that is when you're supposed to do an in-depth study of everything that you've learned. The worst mistake you can make in your clinical year is to start reading textbooks. Now it's time to take good notes. Then it's time to review your notes and the slides. If you start reading textbooks, then you waste a lot of time and you will learn very little. Your clinical year is not supposed to be when you read textbooks. Now is when you're supposed to read textbooks. And I made it easy for you. May have read a lot of textbooks. I give you condensed information. You know. All right. Again, MS supportive therapy, yeah, they need it. Oh my goodness, they need this stuff. Every single one of it. Does it help? I don't know. None of my patients have been able to move from disabled to able to work because of any of this. But it helps to some extent. The government pays for it. Many, many times their children get paid to take care of them. You know, I know a woman, my current patient, she was in real estate. She knows how to do real estate business so well that she got married and introduced her husband to real estate. And about 5 years into their marriage, when she was 35, she got down with MS. Now she's bedridden, completely incontinent. And guess what? Her husband now runs the company with another woman he married. And this woman is now being taken care of by her son and her daughter. And she's so lucky. God gave her good children. They care so much about her. She can't even go to the bathroom. She has bed sores. She's bound, wheelchair bound. The only thing she has movement of is her arms. Nothing else. And I'm just like, well, the truth is, think about it though. Think about it. It's tragedy. Is it better for the man to stay with her and cheat on her and give her a heartache on top of it? It's a difficult thing to deal with. I look at it and I sit down and I think about it, and believe me, I can't even blame anybody. Because you have to sometimes put yourself in other people's condition, like, what is the best thing here? Because you know what, if the man stays with her, he will cheat on her.
You didn't love her.
Right?
You didn't love her then. What happens if for better or for worse?
Like that. Life, when as you come up in life, you realize that it's a lot more complicated than that. You know, and there is no, I mean, rural communities have solutions. In my community, that woman herself will marry another woman for the man. She will be the boss. And the woman, and the women among themselves understand that arrangement, where a woman will marry another woman for a husband. And if she misbehaves, she gets to say, no, this is not working. People do it. Some infertile couples, the woman will always go to marry the woman. That was when they were having this debate in Africa one time about polygamy. People don't understand polygamy. Polygamy concept in some cultures is very complicated. It's not always the man's affair. In Ghana, the women rule the homes, not the men. Right? So in that situation, I couldn't in good faith, I didn't know who to blame. Because if the woman didn't get MS, the man would not do what he did. Okay, if the man was to stay with the woman, do we have to castrate him so he doesn't cheat on her? I mean, she has enough trouble with MS to deal with her husband cheating on her.
You should at least help take care of her.
Well, I don't know to what extent he's contributing, but I know that it's not with her, it's another woman. And she talks about it with pain. Whenever she talks about it, it hurts her. So I know it was not something she was involved with. You know? And I mean, just think about it. You will see this in practice. And sometimes you will realize that life is complicated, to say the least. And sometimes the best thing is, don't even try to understand it. Just help the person in front of you and hope for the best for them. Because you don't know everything, right? You will never know everything. All you know is, this person is in pain. I can do this. Do that. And let them go. And you move on. Because you don't even know what lies ahead of you, right? I've seen a specialist that told my patient, oh, with this kind of disease, you have 6 months to live. He was dead in 3 months. He was the one that told my patient he has only 6 months to live. The patient went back for a 3-month follow-up. So the doctor just died yesterday.
Wait, the doctor died?
The doctor that just told my patient he has 6 months to live. He was dead in 3 months. I'm like, I mean, the truth is, what do we know? I mean, just do what you can and move on. Don't blame anybody, you know. Judge nobody, see no evil, hear no evil, help everybody, hurt no one. Move on, you'll be fine. When you try to understand what you can't understand, then you make a mistake. You start blaming people for no reason, and be careful. Because what I've seen in life, the most homophobic people I know end up having kids that challenge their beliefs. Even pastors. I would disown him. I'm like, be careful. You know, what you fear the most tends to be what befalls you. And the best position you can take in life is do your best for everybody, help everybody, hurt nobody. Every time you'll be able to walk away knowing you did your best for everybody. Any day you cannot walk away from a patient knowing you've done your best, that's the day it's time to surrender your license. Because you're gonna pile things against yourself and you will wish you never had anything to do with healthcare. So, like I was saying, when MS progresses, it progresses in a very strange, not so strange, not strange, but differently in the strangeness of it. Some patients, they get the relapsing remitting course, right? So they're sick now and they recover. They're sick now and they recover, right? But the bad thing is that the recovery is never complete. So you see the patient, he gets sick here, he recovers. But when he gets sick the second time, you see the recovery is not complete, right? He stays at that level of disability for a while, gets another attack, relapses, attack lasts for a while, goes into remission, but never gets back to the previous baseline. So this is what is called relapsing remitting. So the disability keeps increasing. When my patient was first diagnosed, she was so strong, she knew she was going to overcome it. Because by then, she was on a wheelchair, but she could walk. She was on a wheelchair, but she was continent. After about 10 years now, she can't walk. She's incontinent completely. So she had the relapsing remitting. And then there is the clinical isolated syndrome. In these patients, you're never going to be able to make a diagnosis because they end up with one attack, one time. You see evidence of demyelination. They have evidence of inflammation, but they never get the second attack to allow you to make the McDonald criteria. So you know they're MS, but it's MS in evolution, and it could take forever, right? And of course, you have the secondary progressive. When the patient gets the attack, and disability just keep increasing, the difference between the relapsing remitting and secondary progressive is that they never completely go into remission. They get a highly fluctuating course of disease with partial remission in between acute attacks. They don't even get to go to baseline. Why am I bothering you with all this relapsing, remitting, progressive, and clinically isolated syndrome? You need to know it, not because you need to know how it presents, but many times when you send your patients to neurologists and they're diagnosed with MS, you will get a report back that will put them into one of these prognostic categories, and many times that determines how they will be treated by the neurologist. And your patients will always come and ask you, the neurologist said I'm relapsing remitting. What does that mean? You need to let them know that this means that you're never going to recover from this. You're going to keep getting attacked time and again. And as you get more attacks, your disability will accumulate. So start planning. You have to tell them that. And start preparing. That's when you start asking them, are you married? Have you ever been married? Do you have any children? If you don't have any children, do you have any nephews? Do you have anybody? Because you're not always going to be able to do what you're doing right now. You need to plan. You know? And that is when it will shock you how alone we are in this country. There are many, but we are so alone. Many people don't even have families. Many people don't even know who their brothers are. Some women just have children for so many men and die. And the children are left alone in this world. No father, no uncle, no brother, no sister, alone. And the only friends they have are the ones who were in the gang together, or the ones they hung in the street together. And then when this type of things happen, and they meet people, they have nobody. And you find yourself as a provider playing the role of a husband, a father, a wife, giving them advices that should be coming from their relatives. But you're all they got. And believe you me, once you hold yourself out like that as a care provider, oh my goodness, they will lean on you. So don't hold yourself out there like that unless you are there, you're going to be there, because they will lean on you. I'm warning you because this is where compassionate providers get burned. It's called compassion fatigue. There are times you just have to be nonchalant. Even though it aches in your heart, you have to walk away because you are already loaded. Unless you're going to end up where your patient is. But you have to know when it's time to move on. You know, in these communities, there is a lot of pain, and it's self-inflicted by poor choices and lack of understanding. And many people are in the situation that they can't fix because it's too late. And you can only help them cope with the mess they created. And it's going to take every single fiber of compassion in you to take care of them without judging them. Because you would have suffered sometime in the hands, or you might even be suffering in the hands of somebody who is making the mistake they made 10 years ago. And you could tell that person is headed here, but you can't stop it. And as a care provider, how do you care for people you don't care about? It's impossible to do it. If you still work in under-resourced racial ethnic communities, you will see these things. And there will come a time that you have to say, you know what? Like Sylvia used to say, there was a guy that was walking by the seashore, right? And there was this big wave, and it swept out all these starfishes all over the shore, and they were gasping. If the guy was to stay there and toss every single one of them back into the sea, he would be there all day. So you know what the guy did? He looked at every one of them. He's like, he picked this one, just one, tossed him back into the water and said, it matters to this one. And he won't do it. As a healthcare provider, you have to know when to say, it matters to this one. And you have to know. Because the problems you're going to be dealing with are a lot of social problems. But you're going to uncover them in care settings. You can't be everybody's family. You can't be everybody's brother. You can't give everybody what they need. That is why sometimes I like speaking in community settings, because the people don't understand. Those girls don't understand that it matters who you give birth to a baby for. It is important for your baby to have a father who is with you. You want black doctors? You don't have to raise them. You want Latin doctors? You don't have to raise them. They don't fall, doctors don't fall from skies. A father fathered them. A mother put up with crap to raise them. And the community benefits. If you all keep walking away because we're having issues in our marriages, we can't blame disparity on the government. At the end of the day, the community belongs to us. And the way we lay our bed is exactly how we're going to lie on it. You know, when you talk to folks and you see stupid decisions, and even the churches are not helping, because the pastors are more concerned about the tithes and the membership. Tell the people the truth. Because if you tell people with leprosy that they have eczema, and you start treating eczema, they're going to die of leprosy and eczema medication. And you have blood on your hands. You know, it's just a mess, man. All right, moving on. I'm not even done. I've been preaching all this time. Well, this is a quick one. Acute disseminated encephalomyelitis is equivalent, is MS in children, period. That's what it is. MS in children is acute disseminated encephalitis. So whenever you see MS picture, but it's a child, you're dealing with them. And they call it all kind of names. Post-infectious encephalomyelitis, immune-mediated encephalomyelitis, acute demyelinating encephalitis. It does not matter what they call it. If it looks like MS, but it's happening in a child, it's acute disseminated encephalomyelitis. The only difference between ANM and MS is that ANM tends to be more common in males. Okay? It tends to be more common in males, and it tends to have a trigger. So it could be triggered by an infection or vaccination. You notice some people don't want to take vaccines. They don't take their children for vaccine. And like I have a measles outbreak in school, right? It's because many of our vaccines, MMR, diphtheria, hepatitis B, they can precipitate this acute disseminated encephalomyelitis. Okay, and that is the reason you guys, it's not you guys. The incoming class are going to have a debate with the MS biomedical science on some of these issues. You know, Yeah, I just think it's good. Because we want to start doing more with all the other programs. Okay, so like I was saying, you see, childhood and adolescent, male preponderance, headache, fever, vomiting, seizures, lethargy, stupor, depending on which area of the brain is affected, you can get all these symptoms. Again, remember, it's neurodeficit with fever. I gave you a good table here comparing MS to this ADEM. Again, he has a precipitation event. It presents like an encephalitis because that's what it is. ADEM is non-progressive. Okay? MRI pictures is all over, but MS is in specific locations. Okay? Prognosis in ADEM is very good because recovery is full and complete. You don't have residual disabilities. Okay? How do you treat it? Exactly how you treat MS. High dose steroids, taper. If the steroid don't work, you give plasma exchange, right? That's your second line treatment. If push comes to shove, you use immunosuppression, cyclophosphamide and mitoxantrone. Those are immune suppression therapy. Oh, please, I'm tired. All right, I'm going to finish up. How many months do we have? You see, I have EKG. I'll finish next. You want me to finish?
Next time.
You want me to finish? I mean, I can. I'm tired, but I can keep going. But I think we should stop, right? Yeah, let's stop now. I'll be back at 3 o'clock, and then we'll do EKG in 30 minutes. Any questions? Who is talking? What did he say?
Is there anything for EKG uploaded?
Yeah.
Yeah, there's not been uploaded. Oh, there's?
I did not upload anything for EKG.
No.
Okay, so
What are we going to do? We're going to do EKG.
I thought we were doing brain surgery.
No. I want us to do it differently. Because this is your final. I need everybody to know today where they stand on EKG.
Are we going to do a brief?
Yeah, but it will be what I'm thinking of doing is that I'll give all of you. Anyway, you should all have at least 2 pieces of paper, right? The 9 by 11, is 7 by 11?
8 by 11.
8 by 11, whatever that paper is. At least 2 or 3, and I'll bring the EKG up. You will write what you see on the EKG, and then we'll bring the answer, and then you check your own answers. And I want to collect all those papers at the end of class, right? Okay? No, the reason I want us to do that is because when I call people out in class to interpret EKG, when they get it, they get it. But I don't know who doesn't get it in the class. So I want to be able to tell who is having difficulty where. Because EKG, you must know. Even though EKG is read in practice by machine, I need you to be able to gauge when the machine is correct or when you think the machine is wrong. You should be able to do that. And today is our last opportunity to do that. That's why I want to change the way we do the review, so that I'll bring up the EKG, we'll say, okay, write what you think it is, write it down, and then we'll go over it. And if you missed it, you should know why you missed it. And I want to know who missed it. And the reason I want to know is because your final is next week. Right? I need to be able to meet folks and make sure that you're all on the same page. Because in your finals, you're not going to be lining up here. That's finals. I'm not taking questions. All right. I'll be back in 30 minutes.
Dr. Martin?
Yes. Sure. Yeah.
I sent you like half of this picture last week, but so this would be considered paroxysmal because it's starting, but it doesn't stop. So
Well, it's not. Is it a tachycardia?
yeah. Well, you said it was. You said you have this as the answer, but then we talked about that it probably is not accelerated idioventricular. And so then I was trying to see if it was paroxysmal functional tachycardia.
Okay, wait. Whatever this reading is, instead of from here, there is no P wave as such, right? The QRS is not prolonged, so it's PJT.
It is PGT. Okay. So and then it's paroxysmal because it's starting.
Sorry.
It doesn't have to stop though.
No.
Okay, just has
You
to start
have to
randomly.
see it begin or end.
Okay.
Never
Okay.
both.
Okay. So
Yeah.
you can sometimes have to differentiate between PJT and accelerated idiom.
That's correct.
Okay.
Yeah. The thing though, the difference between PJT and ARR
Is
is
the QRS.
the rate
Oh, and
and the
okay.
QRS.
Okay.
Generally speaking, accelerated idioventricular rhythm will fall within normal rate, whereas PJT will be in the tachycardic range.
Okay. Over 100.
That is
Okay. Got it. Thank you.
For sure, though, you're getting
I've been doing a lot of traveling.
But for the exam, I memorized everything and I wrote down.
Yeah, me too. This is
Just, the exam was doable though because you had choices and you knew you can eliminate, you can like look for those things.
No, but like I wouldn't even forget one of the rules because it was all on the spreadsheet.
And it's been a while, right?
I'm just
It's
gonna
not
read
like
it.
he's gonna bring us.
Yeah, it's not for grade. I think you just want to see like, do you need extra help when you're not asking for it? It was like, you're gonna know when I take the test whether I need help or not. I can help if I didn't fail.
Sounds like I'm about to drop the
I just told Jen, I said I don't snack as much because when I go home, I eat too much. So I have to cut myself down.
When I go home, I'm eating that.
Oh, see, I eat too much. My aunt is a bad influence.
Is there any more donuts left there?
There's a lot.
Oh, there's a lot. I just want half. Can I get half of the glaze?
Yeah, the last part she brought didn't make it finished.
There is a lot.
He said we were doing it in 30 minutes.
We do one thing.
He said we're doing this in 30 minutes.
Oh, yeah.
Do I have a Hawaiian shirt? No. A Hawaiian romper.
Oh, I don't have eaten one.
Oh, let's see the white color on here. That'd be perfect. Let's see what he said.
Are you saying the white box error?
Maybe I'll have to see what I like them.
Respect to you?
I don't know if you're not going to.
What?
I don't know if you're not going to bond with your mentee.
Do you know what your mentee is?
No, but we'll find out.
Mary's got first pick. She get whoever she wants.
I know, are you doing it?
I already have two. I've been talking to them since before school started, yeah.
Lucky man.
Love that, Marty.
I don't know. I think they're doing the match there during that mixer thing.
Don't give me somebody's name. Or going. Give them back.
Stan, your audio is so good.
Yeah?
They're so